Sorry for some technical glitch. Now sorted. So I'm Dr. Kiran More. I'm one of the neonatal consultant working in Sidra Medicine, Doha, Qatar. I'm the host for today's session, and I'll being assistant moderator. And I'm also president for NNF Qatar and the Inspire organization in Qatar. So our first faculty for today is Professor Sudhin Thayal. He's a professor in parental neurosciences and director of Center in Parental Neurosciences in Imperial College London. He's been chief investigator for severe multi-center study called as Marble study, and then most recently published trial, the Helix trial, which was looking at the encephalopathy in lower middle income countries. And he's also a PI for multiple other trials. And we'll start today's session with his talk. Followed by that, we will have a talk from Professor Vishnu Bhatt. He's a director of medical research and professor in pediatrics in the GIPMER Pondicherry. And we all, I think, know Vishnu Bhatt. He's got a lot of publications and he's done multiple trials in cooling, specifically in this field in the Indian region. So we'll be listening to him. Followed by that, we have a panel discussion and we have a very esteemed faculties joining today. Professor Sita Sankaran, I think, needs no introduction. She's a godmother and she's sort of a pioneer for cooling across the globe. She's a professor of pediatrics in Wayne State University School of Medicine, Detroit, Michigan. And she's been in Detroit for almost 26 years. And she was the PI for the very first trial, NICHD trial for cooling in HI. And that has set the sort of the ball rolling for cooling in across the globe. And she's also co-PI for multiple trials. And she was the pioneer in describing the MRI patterns in brain injury, and she's one of the co-PI for this Helix trial as well. So she will be participating in the panel today. We have a more esteemed panelist today, Dr. Dinesh Chilra. He's a director of intensive care Royal Children's Hospital in Hyderabad. And again, Dinesh is a very popular faculty in many sort of conferences in India and even some overseas. And he's got numerous publications. He's a joint secretary of NNF in last year and this year, and chairperson-elect of IIP Pediatric Intensive Chapter 2022. We also have a panelist, Sridhar Kalyan Sundaram. He will be representing the sort of neonatologists from the Middle East, because this discussion do apply to the Middle East as well. So he's a consultant neonatologist working in Danat Al Amarat Hospital in Abu Dhabi, UAE. He's trained in GIPMER, PGI, and then also Cambridge, UK. And he works as a consultant in Glasgow and also has numerous publications and also interest in this field. We have Dr. Ismat Jahan. She's an assistant professor and working in Bangladesh, Sheikh Mujib Medical University. She is one of the site coordinator for Helix trial, and she's representing today's as Professor Shahidullah couldn't make it, but she'll be sharing her experience of participating in the Helix trial. And last and not the least, Dr. Suman Rao. She's a professor, St. John Medical College, Bangalore. She's a consultant and Department of MCA and coordinated a lot of trials, including the KMC trial. She's also chairperson for the perinatal committee and Milan forum, and more than 100 publications, 140 paper presentations, and lots of lectures. And she's going to take the lead to moderate this session and try to steer the session in the right direction. So a lot of responsibility, Dr. Suman. And Dr. Arvanan is my colleague. Sorry, I missed his slide. He's also one of my colleague who's trained in Canada and consultant attending in Sidra Medicine, Doha, Qatar, and is our neurocritical lead. So he'll be also co-moderating the session. And without delaying, I will hand over and stop sharing the screen, and I'll ask Dr. Sudhin to start the session. Over to you, Professor Sudhin.
Okay. Thank you, Kiran, for the kind introduction and organizing this webinar and inviting me to talk. So I'm going to discuss the Helix trial. results and the implications. I hope most of the delegates participating in this webinar have already read the Helix paper. If not, please do read it fully, not just abstract, read the paper fully. But this is a brief summary. So it is an open label phase 3 randomized control trial with masked outcome assessments. 408 infants from South Asian United units with moderate and severe encephalopathy were enrolled and randomized. And then the intervention group was whole body cooling. Control group was usual intensive care with avoidance of hypothermia. And the primary outcome was the composite of death or moderate or severe disability at 18 months. So, and the primary outcome was seen in 50% of the cooled infants and 47% of the control infants with a p-value of 0.55. And we had a primary outcome in 97%. So there is a follow-up rate. And the conclusion of the trial was that the whole body cooling does not reduce death or disability after moderate or severe encephalopathy in LMICs. So that's the trial in a nutshell. So what I'm going to discuss today is not the endpoint, but how we got there, the making of the Helix trial. Because before we get to the final point of one of the greatest moments in our history, there is a lot of net practice that we need to do, a lot of practice matches, and then we get to the final match and the final win. So that's what we did with the Helix trial. So this is a decade of work by a lot of people from India, Bangladesh, and Sri Lanka. A lot of very passionate and committed people. One of them is joined as a panel here, Ismat Jahan. So before the trial, there was almost 5 years of feasibility studies and pilot studies, and then we did the main trial. So what you actually see in the Lancet, the 10 pages, is actually 10 years of work. So what I mean by pilot studies is that pilot studies, when we do, they are not powered for the primary outcome. That's how you differentiate a pilot study and a main trial. And you can either use a biomarker outcome or a short-term outcome. But essentially, they will not have adequate power for the primary outcome. And you don't necessarily need to have an IDMC in a pilot study. But of course, when you do a main trial, you do need to have an IDMC. If not, you're in big trouble. And you don't need the same governance requirements, and smaller teams can do pilot studies. But it's absolutely essential to do those before you jump onto the main trial. So like I said, that went on for many, many years before we embarked on the Helix trial. So a lot of net practices, a lot of practice matches, and then the final game. And of course, we cannot say we've won a lot of practice matches, just give us the World Cup. It doesn't work like that. You do need to win the final game. And that's what we had eventually. So I'm just going to discuss some of the decisions we made in the Helix trial and how we got there, essentially the making of the trial. So how did we select the population that we recruited into the Helix trial? So we all know, I'm just going to use India as an example here. We all know the population is very diverse. Some of the richest people in the world live in India. And of course, some of the poorest people live there too. And whom do you choose? This is a famous inverse care law, initially published in Lancet by a very enterprising GP called, general practitioner called Julian Tudor-Hart, who died last year. So he coined this for the first time, the inverse care law, which we all know now, that the availability of medical care is inversely proportionate to the needs of the population. So in India, we have top-end private hospitals there in blue, which has got the same facilities and service the population, which are pretty similar to high-income countries. That's at the top end. But they do have lower delivery rates and very high cesarean rates. So many hospitals, like we did explore, including Manipal Hospital, but it had a cesarean rate of almost 80%. So I'm not sure what the burden of encephalopathy in those settings are. But of course, if cooling is effective in those settings, it doesn't mean it can be extrapolated to all other settings. And if you go to the other bottom end, where if you go to the villages and tribal population who don't have access to proper healthcare, which unfortunately does form a big chunk of India, as in sub-Saharan Africa, cooling clearly does not work. It's dangerous to do cooling there. And one of my colleagues, Nikki Robertson, has shown that if you do cooling in those settings, you're going to increase mortality. And then there's a big chunk of tertiary and secondary care with a huge burden of encephalopathy in India. But we decided to go towards the top end, just because we want to be make sure cooling was safe and effective in those settings before going on to lesser resourced secondary and tertiary intensive care units in India. So the population, the hospitals we selected were public sector hospitals, academic centers with moderately high burden of HIE, usually around 5 to 10 per 1,000 live births. And all these hospitals had facilities for ventilation, cardiovascular support, and a two or three tied medical care. So there was a specialist neonatal consultant, and then in the UK, we call that as senior house officer or a registrar. So those were junior doctors equivalent there, and a neonatal nurses with a ratio mostly between 1:2 to 4. So that is the sites, and this is one of the trial sites in Bangalore, in Indira Gandhi Hospital. Although we had very good relations with one of the nearby hospitals called Vani Vilas, who had a huge burden of encephalopathy, which was also kind of tertiary intensive care. We did not feel cooling would be appropriate there. So that's why we chose a nearby hospital called Indira Gandhi. This is the neonatal intensive care unit there. As you can see, the cooling is being given by a Hypothermia machine there. And these are the trial sites of Helix in India, in South India primarily. Same Hospital in Mumbai, Indira Gandhi Hospital in Bangalore, 2 hospitals in Madras, Kelani University in Sri Lanka, Trivandrum Medical College, and BSMMU from Dhaka. So these were the Helix trial sites. Now, the second issue is how did we select these babies? How did we make sure these babies did have moderate or severe encephalopathy and not mild encephalopathy? So if the key to it is to do a very good standardized neurological examination. So we had certified examiners at all sites. So this is a structured examination that Siddha Shankar had developed for the NICHD trials and has been validated extensively in a number of high-profile publications subsequently. So this is exactly what we use. There is a system for training and certification of all the investigators and the people who were recruiting, which both Siddha and I did. So all of them are certified and validated. These exams are never available online, and also there are a number of documents that's freely available if anybody wants to learn this. But it is absolutely essential to do a structured examination. Otherwise, you will overcall mild HIE as moderate for sure, unless you use amplitude integrated EEG alongside. I mean, in the UK, nobody is very good at doing this. Even in the UK, most people don't do a proper neuro exam and are cooling babies with mild encephalopathy. But if I ask my colleagues, they will invariably say, oh, no, we don't cool mild HIE, it's all moderate. But unless you do structured examination, you will end up cooling mild HIE for sure. So this is what we did for Helix trial. Now, why is the standardization so vital? Because we really want to pick up the high-risk group, the high-risk infants with moderate or severe HIE. But why is that so important? So this is a graph. Just look at this graph carefully. I'll show this again. So this is plotting the power of the study against the control event rates. By control event rates, what we mean is the adverse events in the control group. So that's control event rates. The sample size of any trial depends on the control event rates. So any intervention in newborns will have around a third relative risk reduction. You can pretend it has got 100% relative risk reduction and has smaller sample size, but in reality, it doesn't work like that. So if you assume a 30% relative risk reduction, this is a graph you will get. So imagine we are doing a trial of 400 infants and your event rate is 50%. You have then around over 80% power. Now, if you recruit infants with milder encephalopathy or milder brain injury, your event rate will come down to 30%. All of a sudden, your power of the trial is down to less than 50%. That's a disaster. Then you cannot conclude anything. And of course, if the event rate is much lower, you're in big trouble and something is seriously wrong. So that is why the standardization of encephalopathy is so vital. But we did not use COT pH as an inclusion criteria, and I'll tell you why. I mean, of course, COT pH is a useful indicator because metabolic acidosis may indicate a recent hypoxic event. But more importantly, lack of acidosis may suggest lack of a significant event as well. But the issue in LMIC is that outbound infants rarely have a COT pH done. And although many trials do report as COT pH as an inclusion criteria in LMIC, the denominator data is rarely reported. So I don't know, how many babies do actually get a COT pH done, especially among outbound babies. And that limits the generalizability in LMICs. But instead, we use pH at admission, metabolic acidosis at admission, which was available in more than 90% in the Helix trial. And we made sure we excluded alternative causes of encephalopathy, metabolic genetic causes, and so on. Now, how did we fine-tune our intervention, and what kind of pilot studies did we do? So this was the first randomized control trial, pilot randomized control trial we did. Like I said, it was not powered for the clinical outcomes. So we used something called phase change material, which is a bit like ice, but instead of melting at 0 degrees, it melts at a set temperature, 27 or 28, whatever you want to set it. So this was this is the first human demonstration of a phase change material for therapeutic hypothermia. So this mattress was developed by a company called Crymeta. It's pretty cheap, just 100 pounds, which will be 10,000 rupees, Indian rupees. And this is the neonatal unit in Calicut Medical College that you can see the photo. So we appointed around 6 research nurses to do the study, at least to provide a good one-to-one care when they were getting cooling. So we managed to do therapeutic hypothermia with phase change material, but my concern was both induction and rewarming cannot be controlled because there is no induction or rewarming phase in those. And the cooling efficacy is dependent on the ambient temperature. So when the temperature was pretty high, which can happen in tropical countries, it doesn't work. But we found that we used Thompson's criteria as an inclusion then, in this trial rather than NICHT criteria. But we found that was just not good. We are recruiting infants with mild encephalopathy. We also found that there was a lot of white matter injury in this population, a lot of microcephaly. So there was something which some population differences were apparent in the small study. And then we went on to develop, we got a grant from the Gates Foundation, and we went on to develop this servo control cooling device, which is essentially like an old Nokia phone. If you people still remember, this is the Nokia version of the iPhone that we now use, but it does the job. There's only one set temperature of 33.5 degrees. You switch it on, it just maintains that. And then you can switch a button off after 72 hours, it will rewarm at 0.5 degree per hour. So this is a device we developed, was just costing 500 pounds, around 50,000 rupees, in collaboration with industry partner called Inspiration Healthcare. So our only condition was that until we have the results from the Helix trial, they should not market it because I don't want to market a device. We're just going to, where we are uncertain about the safety and efficacy, and the company was pretty happy with that. So this is one of the meetings we had in Calicut at the time. So one of the representatives, Nikki from Inspiration Healthcare, or there, and you can see Professor Vishnu Bhatt, who was an absolute pioneer in this field and a true inspiration figure for me. And this is Sruthi, one of the DM fellows doing a study on cooling at Shipmer at that time. So we did the initial pilot studies with this machine. So this is the baby we used, the trial in Calicut as well. But eventually, both these hospitals could not participate. In Calicut Medical College, you thought it was more like an upper secondary level care than a proper tertiary full-blown. And in JIPMA, there was a lot of nursing shortages, and getting it, hourly data was difficult. So eventually, both these trials, units could not participate, although there were a lot of credit does go to these two centers, both to Professor Bushnu, and also to Professor Kumuda from, she's not in this photo, from Madras Medical College, who was also present in that meeting. And then we did some pilot studies using this machine in Madras Medical College. So this is the data from about 120 babies, 58 cool babies, and 112 infants to usual care, which is kind of normothermia, although we didn't measure the temperatures of those infants in the study. And the mortality rate was half in the cooled infants, which was quite reassuring. Of course, you cannot say anything about the safety and efficacy of cooling from a non-randomized trial, but this was reassuring. And then we went on to do the full main helix trial. And the main helix trial, we used this machine called Hypothermia. And the reason why we used that was because there was no downloading function of all the data in the Hypothermia helix, and we wanted to examine the rectal temperature every minute, which we could do with this machine. So the key question, of course, you people would ask is, did we actually achieve the target temperature within 6 hours? Which we did. This machine was highly effective. Within 10 minutes, you can really rapidly cool down infants with this machine. And all except 3 infants did have rectal temperature of target temperature less than 34 at 6 hours. And in the 3 who did not have reached that temperature by 7 hours in the next hour. Now, we use normothermia as a control group, although this was not, we were wiser by that time by the experience of the original cooling trials, that Professor Sita Shankaran and the Toby trial that Imperial College did earlier. Because all the original cooling trials had a lot of hypothermia in the control arm, which we now know will worsen the adverse outcome. So the adverse effects of hypothermia is several times higher than the beneficial effects of cooling. So Sita was absolutely adamant we should have strict guidelines for avoiding hypothermia, which I'm quite glad we did. And we also measured the temperature for 90 hours, not just 72 hours, to make sure you don't get a fever later on. And then we continued the measurement for the first 1 week, 8 hourly later on. And we avoided hypothermia by setting lower temperatures in the radiant warmers and a lot of other things. But despite all this, 10 infants did have at least 1 episode of hypothermia, because it's just so difficult to prevent in high resource settings. Or the high resource settings in low-income countries, hypothermia is just so common. It's uncommon in sub-Saharan Africa, where you don't have radiant warmers, but in the UK, hypothermia was very common prior to the cooling trials. But all the ones who had hypothermia had adverse outcomes. So the ones who had a temperature of more than 39, all of them died. The ones who had temperature between 38 to 39, they were survived but had disability. So be very, very careful of avoiding hypothermia in these infants. Now, was the consent rate in helix trial truly informed? It's never, this is one of the biggest challenges, not just in LMICs, but in the UK, because parents just have a few hours to make a decision when their child is just so sick. And it's very easy to say yes without understanding what you're signing up to. So we made sure we trained all the people as much as we can. A lot of mock training went on before they were allowed to consent. And then we video recorded all the consenting. And then we analyzed all these videos in a quantitative way. So we looked at how empathetically the clinician was talking to parents. We looked at whether they provided all information about the trial. And then we looked at whether they had the autonomy to withdraw from the trial or not to participate without giving any reason, and without and understanding that that would not affect the quality of the care that their infant would receive. So it all scored highly on these quantitative measurements, but always, as always, the devil is in the detail. So we then went back and did qualitative interviews with the parents and also with the clinicians. So this is one of my fellows, Sudeepan. So she did his qualitative interviews. And then when we asked these parents, they said, yes, we did participate. We participated because the doctor told us to. They had complete trust in doctors, and that's why they did, which is a good thing. This is the same thing they would do in the UK as well. And they felt that the treatment was beneficial, and it should be given to more people. So this was before we unmasked the data from the Helix trial. They did not know the results, but they thought the cooling was pretty beneficial. Same from clinicians. So clinicians really was finding it difficult to explain the concept of randomization. And this is an issue, not just in LMICs, but in the UK. It's very difficult to explain randomization to patients. They would just want the intervention arm, not the control arm. And clinicians were not happy because a lot of hospitals were already cooling in LMICs. So they had this thing we call as moral distress. Now, how did we ensure randomization quality and the quality assurance of the trial? So we had a web-based remote randomization with a strict audit trail and inclusion criteria logs. So what I mean is that if the infant is more than 6 hours, 6 hours and 1 minute, then it will not allow you to randomize. And we cross-check this by checking the time of birth to ensure this integrity. That's absolutely important, because by people trying to help, people might push a baby 7 hours of age into the trial, just trying to help, but that's not good. So this process will not allow that. And of course, we examined the temperature data by downloading it. We had extensive training and very dedicated and committed research nurses and a core team of fellows at each of those sites. That is absolutely crucial. And whenever I appoint a research nurse, I tell them it's absolutely fine to have missing data. I don't like it. They will get they'll get told off when there's missing data. But if you force, that's your last day with our research group, you'll be dismissed instantly. So, and they knew that. They were really, absolutely committed people. I really hats off to their hard work, and we couldn't have done with the dedication of commitment of the team. And of course, there were automated algorithms to look at the data accuracy and so on. And all the data was checked at multiple levels, by the local levels, local PAs, trial managers, and we went through every single variable in every single case. And we, like I said, we examined the videos of all consent and stored them. Whenever there's almost all cases we used to discuss in real time. There's a WhatsApp group, we just used to discuss any case. If there is any complex case, both Sudha Shankaran and I used to discuss management. Assessment of Baileys again was cross-checked. Each form's photos of Baileys were taken. Not because a lot of things are we do a standard in any clinical trial in the UK and routinely, but we went an extra mile. Not that we didn't trust the local teams. Of course, we had, I had they're absolutely committed teams. But in case people points, we just need to be absolutely sure the data quality is spot on when we do these kind of trials. Now, why did we choose a primary outcome of death and disability at 18 months? All the high-income country cooling trials have done that. And that's for a reason. This is a well-accepted and standard thing that the primary outcome for any neuroprotective intervention should be 18 months, a composite of death and disability, because they're competing outcomes. I would have liked if we could do an assessment at 1 month. It would have made my life much easier because all my work is on clinical fellow, but we can't. We cannot assess the development prior to the age of 18 months. That's the earliest we can do. So absolutely mandatory primary outcome should be the composite of death and disability, because if you have more death, the disability can be artificially lower and vice versa, because they're competing outcomes. And the issue in using this outcome in LMIC is that the follow-up is extremely challenging. Often there's a migrant population, they change homes, not just from one place to another, different states altogether. And I'm not aware of any trial that has got a high rate of clinical trial that has been done in LMICs with a high follow-up and a rigorous neurodevelopmental assessment. So this was a huge, very tall order when we started off, but really admiring, hats off to all the people who managed to do this. So people traveled, investigators traveled long distances, taking flights at times to travel to different states to do the Bailey examinations. And it was especially challenging during COVID. So we had to do all those PPE stuff, mask, and use open air assessments, and so on. So all the examinations were standardized, and they did masked assessments of the outcome. Now, we had a very experienced IDMC team in Helix trial. And why is that? I'll tell you why is that important in a minute. So this team had two of the top people in the field, Professor Ebert Laptuk, who was a PI of a number of cooling trials, including the delayed cooling trial by NICHD, and Naren, one of the most respected people and an authority in the field, and Professor Shabar Jaffer, Professor of Epidemiology and head of Liverpool School of Tropical Medicine, absolute leader in epidemiology and statistics. So, and then we also had two neonatologists, one from the UK and one from India, Niranjan Thomas, which many of you would know, very passionate and committed people. And there was a clear statistical analysis plan, and the protocol was published prior hand. And in clinical trials, it's absolutely mandatory to stick with the statistical analysis plan. If you say, for example, if one of your outcome is neonatal mortality, it's not same as mortality at discharge, and you cannot use it interchangeably. And you need to specify mortality at 20 days is not same as mortality at 30 days. So whatever you say in your statistical analysis plan prior to the trial, you should just do. So interim analysis was done 5 times during the trial, and the IDMC was watching like a hawk. And once the trial results were published and there was harm in one group, both Sita and I went back to the IDMC and said, look, why did you not stop the trial? Because one of the previous trials that Sita Shankaran did, the optimizing cooling trial, was stopped for futility. And they were absolutely clear. They were really watching, like I said, like a hawk at the data. And when we went back and looked at the mortality, the data results we would have after each 100 recruits, and this is what we found. The first 100 recruits, absolutely no difference in p-value, just one p-value, same event rates in both. First 100, again, no difference. First 300, again, no significant difference. And it's only when we got to the full 408, more than 400, the difference came. So the IDMC did make an absolutely correct call in continuing the trial, but of course not allowing it to go any further than originally planned. So really hats off to the hard work of the IDMC as well. So then the final thing is whether the Helix trial reporting was comprehensive, which we think is. So you should read that paper. There's extensive data, both in the main paper and also in the supplementary appendix. So we could have easily published 10 different papers from the data, but we decided to just publish one paper with all the information in. So it'll take you a good afternoon to read the paper carefully. And before we published, unmasked the data, when we had a meeting of all investigators in the team, and we interviewed all the teams separately and recorded this, because it's pretty common in randomized controlled trials. Once we unmask and analyze the data, some PIs may not like what they find, and they might, so we just made sure everything was recorded prior to unmasking. And I was really surprised at the peer reviewers. They was just so supportive, and they're just so impressed with the quality of the Helix trial data, and same with the Lancet editors. But do read all the comments about the Helix trial, which is published in the Lancet, and the reply, and again the supplementary appendix. So that's again was quite pleasing. But what was so different about the Helix trial and high-infant country trial? So here we are looking at the three main cooling trials. Then NICHT, the first whole body cooling trial, NICHT trial published in NAGM now almost 15 years back, led by Sida Shankaran, CoolCap trial, and the Toby trial, led by Imperial College. If you look at the death, the outcomes of death, disability, follow-up rate, and sepsis rate was pretty much the same in all the studies. Birth weight was half a kilo lesser in Helix trial because the population was different. But the striking differences are in red. Hypothermia, like I said, was very low in Helix trial compared to other trials. But look at the incidence of seizures. Many more infants had seizures at the time of randomization in Helix trial compared to the high-income country cooling trials. And much lower proportion had acute sentinel events like cord collapse, abruption, and so on compared to the high-income country cooling trials. But is the data similar to other cooling trials? I think so. I would, if you look at the birth weight, it's pretty similar. If you look at the perinatal sentinel events, it's pretty similar in LMIC cooling trials. Most of them had reported event rates, perinatal sentinel events in 5 to 10%. Most of them had a similar nest into thin trial from CMC Vellore, which is one of the reasonably well-resourced private hospitals in South India. They had a nurse to infant ratio 1:3 to 4. Many trials had even worse or not even reported those kind of supportive care. Again, hypothermia in controlled arms. I'm surprised none of the Indian trials have reported that, but I'm pretty surprised. It's extremely unlikely that they did not have hypothermia, but it's not been reported in those studies. Early onset seizures, again, very similar, almost 80%, more than 80% in many of the trials. And I'm really interested to know about Professor Vishnu Bhatt's experience in these early onset seizures in these infants. And of course, Helix is the only one which uses servo control cooling device. All other devices, all other trials use low cost manual devices. So, but if you look at the, so in Helix trial, we were lucky that our event rate was pretty similar. The control event rate was pretty similar to what we predicted. So we had more than 80% power for a primary outcome. But one of the other phase 3 trials, a last trial by Zhou et al. From China, multi-center trial, that trial had a power of around 50%. But other studies, excellent studies, a lot of them led by Professor Vishnu Bhatt, had powers of 30% or lower. The thin trial, again, a very good study from CMC Vellore had 5% power. So these are very useful studies, but we should not make definitive conclusions about clinical efficacy using this. And if you combine all these results, again, it's pretty much similar. So the only 2 trials are reported death and disability in a masked way from LMICs, as far as we could see. But hypothermia does not improve the composite outcome of death and disability when you look at the pool data. So this again, for us was published. If you look into the appendix in the Lancet paper, you can see that. If you look at the mortality, again, cooling does not reduce mortality at hospital discharge in LMIC when you look at the pool data. That's all fine. But when I talk to a lot of my friends, they'll say, no, Sudhin, this is all fine. But in my experience, cooling does work. How do you explain that? So I'm going to explain by using this model. So imagine this is one of the mouse experiments based on the original Paolo's thinking. So this is a mouse, and every time this mouse touches the red button, it gets an electric shock. Every time it touches the blue button, it gets some pellets to eat. So of course, the mouse will keep on touching the green button or blue button more and more. And if you look at what people do, so we start with cooling babies with mild, moderate, or severe encephalopathy, which is continuum. No baby is going to say, I got mild, I got moderate, or I got severe. It's very difficult unless you do a very standardized examination, as we discussed. And then what do you find? The ones with severe HI are dying more often. Then you stop cooling severe HI, you try and focus more on the mild and moderate one. Then you see the moderate end ones are also dying. Then your drift starts again. You're starting cooling just with babies born in poor condition, but with no HIE. And this circle goes on. And this is what that has happened in the UK, not just in LMIs, in the UK as well. So following introduction of cooling therapy in the UK, I think we have eradicated mild HIE. People will say, oh, we don't see, we don't cool mild HIE. That's just suddenly disappeared. So where has this gone? Now, if you look at this excellent data from the Indian Neonatal Collaborative, 17 units, this is the kind of studies we need. 350 infants, 211 cooled. They did not find that therapeutic hypothermia reduced neonatal mortality. But when we look at the pH, cot pH, only 14% had a cot pH of less than 7. So vast majority of these infants would not have met the cooling criteria for high-income country cooling trials. And only 17% were ventilated, and majority for ventilated for less than a day. So these are very much sicker, less sicker infants in compared to the Helix trial or the high-income country cooling trials. In Helix, a vast majority were ventilated, and almost all of them were on inotropic support and so on. But despite this, 17% either died or went on DAMA in this registry data. So this is again, how generalizable is the Helix trial data? You need to go, we need to look at this pyramid again. Of course, there are settings and populations in India where cooling would be effective, but that is pretty low at the top blue end. And the vast majority, unfortunately, that's not the case. Now, and of course, in pediatric and adult cardiac arrest trials, we know initially the original trials 10 years back showed that cooling was effective in that population. Hypothermia was neuroprotective and the standard care was hypothermia. But the recent larger randomized controlled trial showed if we give targeted temperature management or targeted normothermia, it is as effective as hypothermia. So many hospitals are now using therapeutic normothermia instead of therapeutic hypothermia following pediatric and adult cardiac arrest. And of course, you can make any guideline as you like, but any guideline is as good as the evidence you have for that. So is cooling still effective in South Asia? I think that's the wrong question to ask. What we should be now focusing on, why is cooling not effective in these settings? So there are two ways to look at that. One is by using MR biomarkers, and other is looking at some mechanistic work. So I'm just going to briefly discuss this before I conclude. So this is a multi-center study we did called MARBLE study to develop good biomarkers of MR biomarkers of later outcome in neonatal encephalopathy. So we developed specific sequences for this to quantify MR spectroscopy metabolites and to harmonize the fractional anisotropy acquisitions. And what we found was that this metabolite called NAA or N-acetyl aspartate. So this is something that is seen only in the neurons in your brain. And when neurons get damaged, the level of NAA goes down. And that predicts your adverse outcome quite accurately. And so does the ratio of lactate to NAA. But the issue with lactate to NAA is that the spread is much more clumped. We can see the nice spread of NAA. You don't see that with lactate NAA. But you do need to do a lot of harmonization work before you do these kind of studies. It's very easy. All the modern scanners come with these packages. So it's very easy to click a button and get the data, but that data will not be accurate unless you do a lot of optimization and harmonization work. So this is what we did. Our physicists went around. We did a lot of work with phantoms, adult volunteers at all the sites in India, Sri Lanka, and Bangladesh. I will not go into details, but there is a lot of technical things you need to do before you acquire the data and before you analyze the data. And particularly because if you do this in 100 cases, you'll get good quality data in only 50. So how are you going to decide which 50 you're going to include and which 50 you're going to exclude? And that'll make a big bias unless you decide beforehand how you're going to exclude poor quality data. So before you even analyze this data, you should have criteria on exclusion, how we are going to do that. And of course, they should be all masked to all the allocation and outcomes and so on. So we had criteria based on the peak line width and a lot of other characters of spectroscopy and diffusion MRI and so on. And then two MR physicists independently performed all the analysis using very validated pipelines. And again, this is the flow chart that's again reported in the Lancet paper. There's a very strict protocol of how you analyze this data. Otherwise, you'll have bias. What MRI allows is to look more deeply into the underlying nature of the brain injury and to look at the subgroups more carefully. So when we looked at the conventional MR injury and the MRI scores, many infants had white matter injury. And of course, therapeutic hypothermia was not beneficial, did not decrease the brain injury in any of these infants. When we looked at the MR spectroscopy, no difference between the metabolite levels in thalamic NA or lactate NA. Same with fresh anisotropy, no difference in the cooled or usually care infants. But this also allows us to look at more detail in subgroups. So when we looked at the subgroup of inborn infants, again, no difference. The brain injury was no less whether it was inborn or outborn infants. NA ratios were similar, so was lactate NA and so was fresh anisotropy. Same with moderate to severe HA. There was no effect of hypothermia in that group. Now, so why is this? Is there any genetic differences or is it differences in the mechanisms? So the way you can look at is by looking at, you can look at the DNA to look at this genetic differences. So we did whole genome sequencing in all those infants in the Helix trial. That data, we're just analyzing that data now. But I'd be surprised if there is any genetic underlying differences. What I think is the mechanisms may be different. So you can look at mechanisms by looking at the expression of genes. So instead of looking at the DNA, you look at RNA. So essentially how things work in your body is that your DNA is telling your RNA, you go and make this protein, and that's how you look at the expression of RNA. So when you have an insult, your expression of RNA changes. So, and this expression of RNA, so you do next generation sequencing, you collect blood in specific RNA stabilizing bottles, and then you do next generation sequencing and you look at each of those genes. So in this graph, what you're seeing is babies with encephalopathy in red and healthy infants in blue. So each of this vertical column is a baby, and each of this tiny line is a gene. And if the gene is upregulated, it's given in red, and if it is downregulated in green. So you can see there's a clear pattern, a difference between HI babies and healthy infants. And the genes which are involved in HI is very different to the healthy infants and also the infants with sepsis and so on. So those genes are very different. And also these gene expressions correlate with the later adverse outcomes. But they also change with time. So gene expression changes with time in babies with HI. So in this graph, what you're seeing is the blue dots are infants with encephalopathy. The darker ones are time points soon after birth, within 6 hours. The lighter ones are later time points. So the lighter it is, so this is done every 6 hours, 24 hours, 48 and 72 hours. So the lightest one is at 72 hours, and in between are 24 and 48 hours. So they separate, but the separation is different to how healthy babies separate. So you can really use this to time the injury when this is happening. And so this is what we did. So we looked at the mechanism. Are there any differences in the mechanisms of brain injury in Helix trial and in the UK, in high-income countries? So in high-income countries, what we see following acute hypoxia is that the HIF pathway, the hypoxia-induced factor pathway, is changed. So typically NADH pathway, EAF2 signaling, and so on. But what we found in LMICs was a different pathway. It's a new mechanism called ferroptosis, which is prominent. And this is a new mechanism that's been described only recently, only a few years back, similar to, just like we have apoptosis, another mechanism, ferroptosis is another mechanism. which is more related to chronic inflammation and so on. But we also found was that there was some HIF signaling abnormalities in the helix babies as well, but the direction of that signal was different. So in the UK population, we found that these were downregulated. So you're seeing in this graph, you got the fold change on your y-axis. So if the fold change is less than 0, is downregulated, or it's in green, it is downregulated. If it is in red, it is upregulated. So these genes were downregulated in high-income countries, but upregulated at birth in the helix trial. So then we tried to look at the trajectory, what is happening. So what we think is happening, and then these are plots that I mentioned from time 0, time T1 is 24 hours, T2 is 48, and T3 is 72. So we have a nice trajectory there. But so the HIF pathway is downregulated at birth in high-income countries, and then it gets upregulated before coming down again. But these pathways were already upregulated at birth in LMICs. So this indicates two things. One is that your mechanism is different, more ferroptosis, more chronic inflammation, and so on. B, the timing is also different. It's probably happening around 24 hours prior to the birth in this population. Now, why is that? What does it? What do we do with this information? Now, these are not things we've been thinking about previously. Is there an effect of ethnicity? Not ethnicity, the socioeconomic factors. How does brain injury, how does these things influence brain injury? So this is a recent data published from the NPU in Oxford, the National Perinatal Epidemiology Unit, by Jenny Kurinsek, highlighting higher risk of death in Indian and BAME population in the UK. So even the deprivation in the UK is having effect on neonatal mortality. We don't know how it's affecting the brain injury. There's some data from Sweden. The immigrant population is having higher risk of encephalopathy. Now, Jenny Kurinsek is a person who did the original trial in Australia. You might remember this trial published in BMJ many, many years back, showing antenatal risk factors were the main reason for encephalopathy in Australia. At that time, the study was very controversial, but this is the data the same team has published recently. So I think we are just learning all these things. There's a long way to go, how these socioeconomic factors are influencing brain injury and therapies. But this is the beginning of that journey. But in a nutshell, these data do suggest hypothermia does not reduce the composite outcome of death and disability in South Asia. And like I said, the underlying mechanisms is different to high-income countries, which might explain the lack of neuroprotection. And we need to study this much more. And I often stop with this slide because I know I'm working with very, very passionate people who always want to do good things. Thank you.
Thank you, Prof. Sudhin. That was an extensive talk. I will not, we are just running behind the time. So we'll go to Professor Vishnuvat to present his slides, please.
Yeah, good evening to everybody. It was nice listening to Sudhin. I thought I will not have any time to talk at the end. So let me share my slides. Is it okay?
Yes,
Hello?
sir. You can see, you can go full screen, sir.
I'm just seeing where I have to see full screen.
Will I address the question answer at the end after once we start the discussions?
Where does this full screen come?
You can go to slideshow, sir, on the top, or you can go to it.
Yeah, either you can go to slideshow or at the bottom, where the 76% is there, just left button of that. Left side of that, there is a, yeah.
Is it okay?
No, sir. I mean, there's a tab just left to this 136%. There's a tab. You just click that on the left side, sir.
Is it too big?
No, sir.
Is it okay?
You can go to slideshow, sir. Go to slideshow, and on the top, go to slideshow. So animation slideshow. In the slideshow, you can go. Yeah, on the top, sir. Little
No,
bit
above
above.
that.
Above that, sir.
Animation, slideshow.
Right, yes. Slideshow, and then go to, sir,
It's from beginning,
from the beginning. The very first tab.
the left side,
Left side, sir. Left.
leftmost.
Yeah, there. Perfect.
Okay,
That's it.
fine. So good evening to everybody. Let me talk about.
I think it's not clicked, sir. I think just can you click again from the beginning?
Now in my screen it is full.
Okay, so
Just the start button from the beginning, you can click again.
no, I think it is just a swap of the display probably. You're seeing the full screen, sir?
Yeah, I am seeing full screen. Shall I stop sharing and try
Yeah,
again?
just stop sharing and share again, sir.
Is it okay now?
Yes, sir. It's fine, sir. Perfect.
Okay, so we were working on prenatal asphyxia for a long time. So for more than 2 decades. Initially, we were looking at these people, unfortunate infants, what to do for them because the mortality was very high. So we looked at various factors which will predict outcome. Like we looked at their initially Apgar score, then we looked at their neurological scoring. We looked at their oxidative stress. We looked at their DNA damage. Various things we looked at. All of them are able to predict the outcome, but did not really help the newborns. So then we got interested with the therapeutic hypothermia, thinking that something can be done for these. The most important thing is that therapeutic hypothermia acts at multiple levels. It reduces the anaerobic glycosis, it improves the ATP level, it acts on the NMDA level pathways, lipolysis, peroxidation, nitric oxide mechanism. Finally, all these end up in free radicals injury. There is too much oxidative stress, which causes the brain damage. So I will not go into the mechanism of cooling because all of you are familiar. Basically, there will be an induction phase, maintenance, and rewarming. My understanding is that rapid cooling, we usually cool within 45 minutes, 1 hour. Most of the babies within 45 minutes, we could cool them, then maintain for 72 hours, and then gradually rewarm over 8 to 12 hours. But this should be done at within 6 hours because that is the therapeutic window, after which you do whatever you do. It really does not help much because by that time irreversible brain damage occurs. And you continue cooling for 72 hours, and the temperature is also fixed to 33 to 34 degrees and gradual rewarming. So rapid cooling, sustaining, maintaining temperature, gradual increase in temperature. So what we used to do is we use the gel packs, which we use for vaccine carrier initially. We cover with the clothes because if it comes in direct contact with the baby skin, it causes injury. So put out the warmer, put a rectal probe, put a skin probe, collect into a multi-parameter monitor. Continuously, this monitor will be monitoring the temperature, upper and lower limit, heart rate, respiratory rate, and oxygen saturation. Everything will be monitored. And any deviation from the set levels, it will give alarm so that it gives a warning to the people that something has gone wrong. People have to attend immediately. So the first study we did using this gel pads. Those days we had only 2 ventilators. Most of the ventilators were occupied with respiratory distress and acute cases where the mortality was very low and survival was very good. So we could not put hypoxic babies on ventilators. So most of the cases will be moderate and severe cases, but severe cases on ventilator who are shocked, who are debilitated already, we never cooled them. Although they were all inborn babies, there was no extramural babies in any of the studies because Most of them did not reach our hospital within 6 hours. Those who come, they did not have their Abgas score or ABG level. Whatever treatment given details were not there. Many of them were in shock or hypothermia. So we did not include any of the extramural babies. So it was so impressive to me, the first study, we could reduce the morbidity and mortality at 6 months by 21%. As Sudhin says, the neurodevelopmental outcome may not be very definite at 6 months, but definitely you can make the changes you can appreciate. So you looked at we did the Baroda development screening, the mean score, developmental age, developmental quotient, the number of babies below the 97%, all were different in hypothermia when compared to non-hypothermia or our control group. Even impaired hearing and vision were also less in hypothermia, but it did not reach significance. So we looked at the combined outcome of death and developmental delay at 6 months, and it was showing significant difference or marked improvement because of cooling. You will be surprised, a moderate hypothermia baby will be in such a neurological state within 36, 72 hours, he will come out as if he had a good night's sleep and smiling at you. So that was the observation what we were making. So number of convulsions were less and number of the anticonvulsant required were also less in the hypothermia group. So I was so impressed by the cooling, although we were doing with the gel pen. So the next DM student came. So I told, why don't you look at the oxidative stress? Because it may be, I initially, as Sudhin says, there could be some problem with the data collection, all these things. But all babies I would have seen, more than 90% of babies I would have seen myself. But others were also seen. So next group of hypothermia and control, we looked at the oxidative stress in the babies. So as the oxidative stress increases, the antioxidant status comes down and oxidative stress level increases, the melandialdehyde and the MDA level increases. So at baseline, if you see, the antioxidant level is almost same. There is not much difference between the cooling and uncooled babies. But when you come to 72 hours, the uncooled babies, the antioxidant status comes down significantly. Similarly, if you look at the melandialdehyde, that goes up in those babies who are not cooled. So if you think there's something wrong with the brain before or the oxidative problems are earlier, how it will change with cooling. And if you look at the neurological deficit at discharge, there was significant difference of 36% to 70%. So risk of developing neurological abnormality at discharge was significantly low in cooling. And we postulated this oxidative stress is the mechanism, probably the cooling reduces the oxidative stress has been found in the study. Next, the PhD student came. So I told, why don't you look at the DNA damage which we observed in hypoxia babies, whether cooling changes it or not. What something similar to what our Dean Sudhin was doing with the genetic studies. So we took the hypothermia and normothermia babies, looked at their DNA damage. We did what's called as comet assay. So we separate the blood sample, centrifuge, alkali denaturation you do. Then you apply electrophoresis. The altered damaged DNA move away from the cell nucleus of the cell. So it will look like a comet when you do the assessment. So as the DNA damage is more, the head will become smaller, less DNA in the head, tail will become longer. So the DNA damage will move away from the nucleus and there will be longer tail as the damage is more. So this is just to show, this is a normal cell where the cell is more round. There is hardly any tail, in the sense the DNA is more or less in the cell. When the hypoxia comes stage 1, 2, 3, if you see, the tail will be mildly long, moderately long, very long. So by looking at the DNA damage, we can say that how severe is the asphyxia in the baby. So what Sudhin was showing in the genetic this thing, it is only the outcome. It is not the primary thing. That's what I think. And we looked at what is called a micronucleus. So in a biologue, the nucleus, there is something called micronucleus, small nucleus. Small nucleus, the micronucleus presence indicates cell death or apoptosis. So more micronucleus you find, there is more cell damage or apoptosis occurred. There was significantly higher number of micronucleus. We count against 100 WBCs and see how many have micronucleus. It's significantly more in those babies who are not cooled. We looked at even the karyotyping we did, the ring chromosome, the interchromated the connections, dicentric chromosome, all were more in those babies who are not cooled when compared to cooled. So we looked at the tail length of the infants, those who are cooled and uncooled, the control. At baseline, if you see, the tail length is almost similar, whereas in 36 to 72 hours, if you see the uncooled one, the tail length increases. Even in 72 hours, it's almost double. So definitely cooling improves the outcome. That I think even Helix trial also has seen that. Now, percentage of DNA in the tail, if you see in the beginning, it is almost similar. Whereas after cooling for 36 and 72 hours, you see the difference between the percentage of DNA, damaged DNA in the tail, it is significantly increased. Even at 36 hours, it's increased. So what is happening is that if you do not cool the baby, you allow the baby to continue to have damage, and you are producing more hypoxic damage in the baby. And if you look at this is a bar diagram showing the DNA damage. The blue one is the cooled one, red one is the uncooled one. So you look at this thing, it remains almost same. Cooling does not prevents the further damage to the cell. It does not reverse, but it definitely prevents further damage. So if you do not cool, it continue to have damage. So that is the problem which I think Sudhin should understand. So now look at the comet tail length. What we did was this study, Sudhin was telling there is no study after 6 months. This we have followed up almost 2 years because he was a PhD student. He could continue to follow them up. So 18 to 24, the minimum was 18 months and continued for 2 years. We compared the tail length with the mental development score and motor development score. So as the tail length increased, more and more damage, the developmental score is different. If you look at the motor development score also, as the damage increases, the developmental score comes down. So we hypothesize that therapeutic hypothermia reduces oxidative stress and DNA damage, as shown in these studies, and it definitely reduces the neurodevelopment outcome at 18 months. And DNA damage and oxidative stress are the main mechanism which causes hypoxic damage in the brain, and therapeutic hypothermia definitely reduces it, whether you do in high income, low income, middle income, or no income, provided the case selection is proper. If you already pull a damaged baby and do a high flown study and record and analyze all these things you do, but basically the infant which you pull makes the difference. Now we looked at the renal damage. We also looked at the outcome, the kidney damage. When you cool and non-cool, there is a significant difference because there are many papers which have come whether we should reduce the drug dosage when you cool or whether you can give the same doses of the drugs. So we were interested in seeing whether what happens to the kidney. If you look at the kidney also, the damage is different in cooled and uncooled babies. Uncooled babies have almost double the amount of renal damage. Fortunately, most of the cooling kidney damage are mild type. The severe ones are not that common. We also looked at the myocardial function. We estimated their CPKMB level, we estimated the troponin level, We did the ECG and echo with the cardiac, just help. And with the cooled and uncooled, if you see, there is a significant difference between the cooled and uncooled babies. Next, we looked at the magnesium sulfate along with the cooling, because by this time, when Sudhin's helix trial started, we stopped randomizing into non-cooled arm because our ethics committee was very unwillingly approved the last study based on Sudhin's study. We showed his study one after another, and they said it is still unconvinced. But after this, we have some consciousness, so we could not randomize them. This I told Sudhin also. We have stopped randomizing to non-cooling arm by this time. So we gave magnesium sulfate to this one group of infants. Other group, we did not give magnesium sulfate. Both were cooled babies. But when you assess the neurodevelopment outcome at 1 year, although it may not be that much reliable, they were slightly better when compared to the only cooling. With magnesium sulfate, it was better. But the problem was some of them were going to respiratory depression, severe sedation, and some of them have to be put on ventilator. This is one of the problems when you give magnesium sulfate. You may ask me, don't you find any side effects? But unlike helix trial, our morbidity rate was very, very low, maybe half of what they have seen. So he was looking at the death or mortality, but I think they should have looked at the morbidity and should have tried to see why the morbidity is so high in helix trial, and probably they should have stopped in between and checked what happened, which they do not do. So the sinus bradycardia and skin changes are the major problems which saw, and skin changes were seen mostly when we are doing the gel patch. But with the phase changing material, there was not much difference. Then we compared the complication between the cooled and uncooled baby. It is almost similar, except the sinus bradycardia. If a cold baby does not have bradycardia, that means he is not cooled. If he has got tachycardia, most probably he has got infection or shock or some problem is there. He needs attention. This you must remember. So there are the systematic reviews also, which showed, which you all must have read, Jacobetto, which showed the benefits of cooling, and also another from low-income countries that Abbott et al. Has done. They showed that there is significant improvement in brain damage or neurodevelopment outcome when you do cooling. So that is the issue. So then we compared our data or outcome with neuromortality and neurodevelopment outcome with the helix trial, and also the study which he was mentioning in Calicut. Except these studies, the mortality was low in all our studies. And if you look at the neurodevelopmental outcome, which was not done in that Calicut study, whereas in the helix trial also, the neurodevelopmental outcome is better. So does Sudhin and Madam Sita Shankar trying to say that whatever little benefit the cool babies will get should not get, or I don't know what is the concept is. Now look at, should we cool babies in our low middle income countries or not, what Sudhin was putting. So my suggestion is that you should offer cooling to all infants if they come within 6 hours. They should have severe significant acidosis and also moderate to severe encephalopathy. What he was telling us, mild encephalopathy, we should not ignore, definitely, because it is labor intensive and it may cause the complications. So moderate and severe encephalopathy. I think with the neonatology in trained person in the unit, it should not be difficult to find whether a child has moderate or severe. Of course, it may be difficult sometimes, but it is not. And if you look at the helix trial, they had a lot of proportion of the infants had brain damage, as he showed in the MRI, and also convulsion. And Sudhin, with a lot of experience, must be knowing convulsion does not occur very early in hypoxic babies. It occurs after 6-8 hours. So if you wait for convulsions, most of the time is bad. I think what has major problem happened is they did not have details of resuscitation. They did not have how they were transferred. Many of them had hypothermia, and more than 70% are outborn. That is why he is seeing such a bad outcome with this thing, which he should be able to understand. And it is not the DNA in the brain or the other thing. We have lower birth weight. We have more infection maybe, but they are not the major issues as I can see. And I say that you should not do cooling everywhere. You should have proper setup. You should have neonatologists. You should have round-the-clock monitoring. You should have radiant warmer. You should have proper cooling device. If you have a servo control cooling device, that is the best. But it is not affordable in many centers. That's the problem. And our experience with the servo control, what our Sudhin has given for a short period, and also phase change material, there is not much of difference, provided your nursing care and doctors are good. You should have a good multi-para monitor. You should have facility for mechanical ventilator. So it should be a good intensive care where you can do cooling. Cooling should not be done in a peripheral level. And also choosing the patient is important. It should come within 6 hours, and you should have a proper protocol for cooling. If you indiscriminately cooling within 6 hours, babies who are hypoxiated at birth, not resuscitated properly, transferred in a poor condition, definitely helix trial will get repeated. In the sense, it will not show any improvement. So my take-home message to in the short time given to me is perinatal asphyxia is a very important problem. So our aim is not to treat perinatal asphyxia. We should spend more money on improving the infrastructure, looking at the high-risk pregnancies, giving them adequate proper management delivery, proper resuscitation, and facility for transfer into a center where they have high facility and in a proper condition. Otherwise, hyperthermia or hypothermia, as rightly said by Sudhin, will cause more damage. So therapeutic hypothermia with or without adjuvant therapy can reduce mortality and long-term outcome. I have no doubt, I am 100% sure about what I'm talking. And what has happened in the helix trial, I think Sudhin himself must be knowing, but he is not telling the truth. That's what I think. So anyhow, I'll close here. I want to thank all those people involved in my group. Most of them were DM students, PhD students, and other department people. Thank you for hearing. And if there is any questions, we'll answer it then. Thank you.
Thank you, Professor Bhatt. Excellent, excellent talk. I think after this, both the excellent session, I'll welcome Dr. Suman to do the further proceeding and do the moderate the panel discussion and further question answer session. Over to you, madam.
Thank you very much. And it's indeed my privilege and honor to moderate this session. And definitely, to cool or not, it's such a hot topic. And that's what we are going to be discussing now. And please tell me if you're able to see my screen. Right?
Yes. You can see the screen and you can go full screen.
Okay, can you see full screen?
Yeah, but it's in the presenter view. Can you swap, use slideshow, the top button? Yeah.
Yeah, then I will do the slideshow. Yeah. Okay, so now we are going to be looking at therapeutic hypothermia. You heard two sides of the story done in the same place. And therefore, now I think it has thrown people into confusion. How should I cool or not? And that's the big question that we're going to be asking today. So we are going to be discussing the controversies, but try to arrive at a consensus so that we have the way forward. So how we are doing this panel is, first we'll have two rounds of questions to our eminent panelists. And then there are so many questions by the audience. So Dr. Aravanan will take up all those questions. And hopefully at the end of this panel, we hope that people do know some sort of guidance of what we should do with our babies, because perinatal asphyxia is one of the three big killers in low and middle income countries, and we need to have a solution to what we could do. So now let's put therapeutic hypothermia under the scanner. And I start with Professor Sita Shankaran, who started all this. You have been working in this field for, I think, decades now. So when you saw the results of the HELIX trial, why did you think was the impact in low and middle income countries different from high income countries? I know we have heard Professor Sudhin already talking about it, but we would like to hear from you. Why did you think it's so different in LMICs? Over to you, Professor Sita. Madam, you're mute, yeah.
We can't hear you, ma'am. Please still.
Yeah. Ma'am, you're unmuted, but we can't hear you.
We need to check whether she joined with the computer audio or.
I can see her audio is joined. Still not able to hear. Some disturbance from your end, ma'am.
Maybe the earphone problem.
Because I think the volume is less.
Maybe we could move to the second question and she could
Yeah.
log out and come
Yes.
back into the same.
Yeah. So yes, we can move.
Ma'am, if you have another device, please try with another device.
Okay,
She
so
could
I
log
think
out and come back many times.
we were very keen to start our panel with Dr. Sita's first comments, but I think we'll have to. Oh, probably we are hearing our own echo through her system.
I think Madam is trying to talk, but it is not clear.
Okay, so in the interest of time, I would like to maybe move to the second question, to the second panelist. And Dr. Dinesh, you are sort of representing all the neonatologists from India. So why do you think the results of HELIX are different in LMICs? And then maybe you can share your experience about therapeutic hypothermia, because I know that you also have been doing this with some good results. Yeah. We can't hear you, Dr. Dinesh. You have to unmute.
Yeah, am I audible now?
Yes.
Yeah, hi. Thanks, Suman, for posing that question. And thank you, Dr. Sudhin and Dr. Vishnu, for excellent lecture presentations. And it's very important for us to come to consensus about what is good for the country and what is good for the babies. Dr. Sudhin, I think after getting trained and coming back to the country, we all believe that we should give best to our babies. And I think there are very few interventions in medicine which are very country-wise dependent, and like I feel as a pediatric intensivist, where the way we give fluid boluses and septic shock, it's a little bit, you don't give very fast like the way you give in septic shock in Western countries. But when it comes to cooling, the physiology about the way it's neuroprotective seems to be quite clear. So cooling as a therapy seems to be quite protective. So we all seems to be convinced. And then we sort of looked at the genetic part of it. We don't know what the genetic changes are because of the mode of the injury. Is it acute injury versus prolonged injury? Rather than sort of, the genetic basis of the people who are living. And India, as you know, is a very heterogeneous population and healthcare services. 70% of the services in India still are private sector, 30% is public sector. Public sector is quite overburdened. And it can be quite stressful. I have been trained in one of the centers, and sometimes in one sort of warmer, we might have to take care of 2 or 3 babies also. So to understand the difference between LMIs, we need to know what was the cause of the increased mortality, both in the control group and this almost going to 50%. When we actually looked at the number of severe encephalopathy, only 20% in each group, and 80% were moderate encephalopathy. So that is the first thing, is to understand the difference between the high mortality in the NICU is one thing. So will that be sort of generalized to the whole of the LMICs? Then when it comes to acute versus chronic asphyxia, we need to probably stress more about the antenatal and intrapartum monitoring, which is very important for us as a neonatologist to probably take our obstetricians into consideration to be more neuroprotective rather than dismissing the therapy completely. Now, the significant number of patients have been from the outbound. And the outbounds, and one of the big challenge, and this we were discussing today, is the mode of transport. A structured transport is what which makes a big difference. So many of the babies who come, if they're hypothermic, it itself is a poor prognostic factor when it comes to outcome of this baby. And of course, when do you start cooling? See, in India, where busy, I know when you are asphyxiated, by the time you counsel them, you tell them you need to move to other hospital, they organize an ambulance, they come to busy places like Mumbai, Bangalore, Chennai, they take good sort of 3-4 hours, and then they come to the hospital, you counsel them, you take through, this takes time. So initiating within the first 6 hours is a big challenge. And one thing which is very important, I really appreciate for sort of highlighting, is it had become that cooling is a norm. And if you cool the baby with asphyxia, so it's enough. I think cooling is one modality of neuroprotection. You need to optimize other things like taking care of their ventilation, optimizing it, taking care of the hemodynamics and optimizing it, prevention of or treating the infection, sedation as and when required for the baby, sedation, and neuromonitoring of these babies, monitoring, doing a cardiac evaluation for them, looking for any sort of coagulopathy for them. These are all part of NICU care of these babies, which is very important. And this is something which has nicely been highlighted by Helix, trying to say just cooling is not enough. It is the overall ICU care which is going to make a big difference. Now, after the Helix, it became very important for us to just let us look at our data, because I never thought we could do an RCT of cooling. So we just started cooling way back from 2012 in our unit. So we now, as a Rainbow, we have sort of 12 centers across the country, but I collected data from 4 of our centers, which are the high volume centers, and also from 2 other units. And this was one of the survey which was done by Manigandan, which looked at which are the availability of cooling machines and who are doing. And they found that majority of the private hospitals, they're still doing in the sort of cooling compared to the public. Okay, can I go to the next slide? So to show my sort of these things. So this is from the unit which I'm working. And we use Tecotherm, and we use some babies critical, which they had kept for a demo purpose. So total 88 babies we had cooled. Total 23 are inborn and 65 are outborn. Or 45 babies we went ourselves and transported with a doctor and nurse. So doctors were either fellows or a consultant, and a self-transport 20 had come. Moderate were 16, severe were 7, and 51 had moderate HI in the outborn, and 14 were severe. Mortality, 68 out of 88 got discharged, 13 went LAMA, 6 in stage 2, and 7 in stage. So moderate 6 went LAMA, 7 in it, because the LAMA cause could you assure that this child is going to normal or not? 6 expired, that is intention to treat, but if you say 21.5% of the babies, if you say LAMA and the expired we include, so we had sort of 21.5% of mortality. Then we start, let us look at other units, how we are doing. And then we included the data from other centers of our 4 centers in Delhi, the Bangalore unit, and the Vijayawada unit. And Dinanath Mangeshkar Pune and SRMC Medical College Chennai, who have been cooling for a long time. So there are 324 babies we have included. And these are the units which have been regularly cooling. 131 were inborns and 193 outborns, so nearly 60% were outborns. Out of this, 1 or 2 were transported by newborn emergency transport. So 50%, above 50% were transport. 260 moderate and 64 were severe, which is just about 20% had severe encephalopathy. Servo control cooling was used in 244 out of the 324 of the babies. If you look at moderate stage, out of 105, 104 survived. Out of severe, 26 babies, 12 survived in the inborn patients, and the 11 expired and 3 went lama. In the outborn category, out of the 155 babies, 138 sort of were discharged, and 3 expired and 14 went lama. In the severe category, 18 survived and 10 went expired and 10 went lama. So severe encephalopathy was definitely poor prognostic marker. So there was nearly 19.17. Then I looked at our Banjara unit specifically to look at some of the markers. So section rate, I think, as you pointed out in your presentation, yes, sometimes there's a more of high risk pregnancy comes to the unit. So we had probably a little bit of little less than 50% had section. A lot of them were emergency sections because sort of a sentinel event, or we had male to female ratio 31 and 57. The umbilical blood gas was available in all the 23 inborn babies. So that's the norm in our unit to do the blood gas for all the inborns. But 20 out of 65 outborns had umbilical blood gas. So some of them were the other peripheral units of our hospital in the Hyderabad clusters. They had to be sent. EEG was done in 74 out of the 88 patients, and clinical seizures were present in 64 out of 88 patients. Chest compressions were given in 20 out of the 88. Positive pressure and intubation was done in 40 patients, and just a PPV in 18 patients. Respiratory support was given to 87.5% of this children, new babies, including HFOV ventilation. When it came to Banjara, when I just said, okay, I was just looking at one of the 57% of a severe encephalopathy baby died, it be inborn or outborn. And when we look at the overall data from all the 6 centers, similarly, more than 50% of a severe encephalopathy baby died. So what I say, it is optimization of your NICU care, which is going to be there. We are collecting our data about their developmental outcome at 18 months in these things. I think I'm not able to present that, but I think disability, the reason to present the mortality is one of the striking thing was it increases the mortality was one of the concerns raised. And that is what was my major thing to share our data. And we would really like to know, the reduction in the mortality is be more to optimizing of the NICU care rather than cooling only is what I have to say.
Thanks, Dinesh. Thank you very much for highlighting one very, very important aspect is that it is the quality of comprehensive NICU care and not just about cooling, which will probably have an effect on outcomes. And of course, people might say this data from Rainbow is what Dr. Sudhin has already told us, that you're at the peak of the pyramid, right up there, and we all know that. But I think what Helix really did was made us all go back and look at our own data. We have also looked at data from St. John's because we have been cooling for a decade now. And just like you showed, our outborn mortality was almost double that of inborn mortality. Our inborn mortality was less than 10%. But our outborn mortality was less than half of what was there in Helix. And St. John's is somewhere midway, I would say. It's not a corporate sector, but it's not like a public hospital either. And therefore, I think focusing on quality of care, like you said, in fact, not only have you presented data, but you have also sort of shown us how it can be made safer by talking about retrieval of babies and not just about self-transport and such things. So thanks, Dinesh. Thank you very much. And I hope we can go back to Professor Sita Shankaran. I hope, madam, that we'll be able to hear you now to know your expert comments on why Helix did not seem to have an impact in LMICs. Over to you, Professor Sita Shankaran.
Okay, ma'am. Can you try one more time? So Looks like I think the technical issue is still there. So I've just devised a option of connecting to my mobile.
Yeah.
So, and we'll just put her on the speaker from my side. Professor Sita, can you pick up your phone? Just pick up your phone and then we can connect you from on the phone. Hello, ma'am. One sec. One sec. Okay,
We'll be going.
can you speak, ma'am? Ma'am, you will have to unmute yourself. One second.
Can you hear now?
Yeah.
Yeah, I don't understand why they will noise.
One sec. I think that it's echoing at my end, so this may not work.
Yeah.
Kiran, can you mute your speaker, not the
Yeah,
mic,
yeah.
the speaker?
No, well,
Mute your
I'm trying to play her on my speaker.
No,
so
no, that's fine, but you can mute your speaker, not the
Yeah.
not the mic. You can't hear, but we can hear. So just go ahead. Mute your speaker.
Okay. Okay, ma'am, can you speak? I think the audio is not loud. One second. Yeah.
Can you hear me now?
There is a lot of echoing, I think.
Maybe she needs to mute her speaker as well.
I have muted my speaker.
The mic and the speaker, I mean.
I think we'll have to come back to you, ma'am. Looks like this is not also working. We'll come back to you, ma'am, with the next question.
I was wondering, Dr. Kiran, if you unmute yourself, put her on speaker on your phone and we mute
That's what
her video, would that work?
that's what I was doing actually, but still there is echo.
Okay. I'm sure that we'll be very, very disappointed if we can't hear Professor Sita. So let's see how before we close this panel, we are able to hear her, but we will move forward now. So we will go to Dr. Isma Jahan, who is actually representing all the investigators of the Helix trial. What was your experience of doing this large trial, Helix? Over to you, Dr. Isma.
Am I audible?
Yes.
Okay. Thank you so much, the organizers. Is it okay? My sound?
It's fine. There was some echo earlier, but it's fine now.
Okay. I really enjoyed the power presentations last hour, and I have been a part of Helix trial since it's starting in Dhaka, BSMMU. So it was nice journey. So from investigators' perspective, let me share the cooling therapy scenario in Dhaka. So till now, no unit, hospital, center, or institution practice cooling therapy in Bangladesh. So we are the first started the cooling therapy as a part of Helix trial. Since its beginning, we were full of enthusiasm, and we were also hoping that this magical treatment therapy would work for our babies. and this machine will be available for our babies, and there will be something for our HI babies. So it did not work. And the thing is, what I understood, or what Helix taught me, that we probably spending more time and effort for proving efficacy of an intervention, rather than focusing on the evaluation of our unique characteristics, LMIC characteristics. So I'm talking about the factors before birth, socio-demographic factors, antenatal perspective of fetal well-being, timing of injury, pathophysiology, and of HI babies in this part of world. So what we understood from different presentations, that these something unique must be there in our babies. So my point of view is, we should rather focus on exploring this uninvestigated, unevaluated area, rather than focusing on proving an intervention. So intervention is far far away from our situation. And I must thank to all these trial team, LMIC trial team, because for them, we are aware of our unique characteristics. We are now getting discussions and all that, conflicting results and controversies. So thanks to all trial team for giving us this opportunity, that they warn and remind, Helix remind us that any trial or any experimental intervention would not work if we do not know our patient populations, patient characteristics. So that is all from my side. I'm sorry, I have no slide to show. So over to Dr. Shumon Rao. Thanks.
Thank you so much, Dr. Ismat. I don't think you have to be sorry. We are so glad that you could come in at the nth minute when Professor Shahidullah had suddenly other commitments. And you so rightly said that first we should know our population before we think of really going into an intervention. That's so true, that we should do our best to make sure that our babies come out well and prevent asphyxia, and only then think of understanding them, think of cooling. I think, but Bangladesh is in a situation where you have no controversy. You haven't yet embarked on cooling, and yours was the only place who started this trial. And now you're very clear that probably it's not going to move forward in Bangladesh. But I think in India and in other places, the situation is a little different, because we have moved quite forward on this path. And that is where we have this thing. So let me now go and ask Dr. Sridhar Kalyanasundaram. What is the current practice in the Middle Eastern countries? And do you think this data from Helix will change your practice in any way?
Good evening, everyone. Thank you, Kiran and Dr. Suman and the team for this opportunity to be with this August panel. I'd like to congratulate Sudhin and Professor Bhatt for the excellent talks and interesting perspectives, we may say. And of course, there is always different perceptions when it comes to differing views and perspectives. So we have to understand both the arguments for and against, and have an unbiased approach. That's my view. In terms of the Middle East, I mean, very interesting scene that we have tertiary centers and we have the level 2 centers. Not everyone will have the cooling facilities, and rightly, as explained earlier, that level 3 centers will be the ones who cool the babies, and geographically, it's not very big. So we have in United Arab Emirates, for example, we have 7 Emirates, which you have the option to heli transfer or road transfer, and within 1 to 2 hours, traffic is usually not a major issue. And the issue we have is that the yardstick medico-legally that is applied here is similar to Western criteria. So they're not going to go by population statistics, and it's a huge variation, multi-ethnic expat population here. So if you say genetic variations are going to impact, will we be cooling the patients who come from US or UK, but not the ones from India or Sri Lanka? It's very unlikely that would be acceptable in a scenario like this. And we know from all over the place. I mean, the perspectives on the genetic part is very interesting, and both Dr. Bhatt and Professor Sudhin had these views. But the key thing is, we know that population does play a role in diabetes, for example, in hypertension, for example. And there are multiple studies, long-term studies, which have been done in a Chinese population moving to US, or in the Framingham study, and even Barker's hypothesis. They say that the people from a certain background have a higher risk, but that doesn't mean that you would not use a certain measure totally in them. And one point I would like to make regarding the population number or the Apex Institute numbers, I mean, if you look at the population of India of 1.2 billion, even 15 to 20% caters to medium to high risk groups. We have good facilities. It's going to be almost equal to the population of US and 4 or 5 times the population of UK. So if you're talking of huge numbers when you talk of a big country like India, and as you said, we have come fairly advanced. As far as the Middle Eastern experience is concerned, there are a few publications, and especially from Saudi Arabia, where they have applied in Saudi Arabia as well. The government setups are comparable to the Western setups, and so the studies have come from them. They do have a similar transfer policy for the sicker babies who are delivered in centers who don't have cooling. They will be transferred, and the expectation is there from the authorities here that we should go by the Western standards. So if you don't cool babies, you may be in trouble if they fulfill the criteria. So medico-legally, we have an obligation. I was looking at the MacCool study where Qatar was involved as well, and Egypt and Saudi Arabia were among the other centers in addition to Canada. Similar to Professor Bhatt's talk on, the brief mention on the magnesium sulfate in cooling, and they also showed comparable results, but it was a pilot study, and I have to follow up whether they're doing a long-term study. So this is the published evidence, but as I'm working in a tertiary center, and many of my colleagues are working in the government institutes, which are tertiary centers, the outcome we have observed, we don't have very solid papers on this, but the outcomes we are observing is comparable to any of the Western data. And population background, the obstetric care, these are going to make a very big impact. So I'll be discussing it in the next point that we will discuss as well about patient selection. So with this, I'll close this part of the talk.
Thank you, Dr. Sridhar. Thank you so much for highlighting that, just like in front of law and justice, all are equal. Similarly, you can't really make a difference and say, you're from US, you're from India, I'm going to cool you, I'm not going to cool you, your genes may be different. So for highlighting that, and also you're going to elaborate on the population. So you also highlighted about the medico-legal aspects, which are so strong in the Middle Eastern countries. I do see that some of the participants are raising their hand. Please bear with us. We will be having a full session on question and answers. And so we will have enough opportunity for that. Now, so let's go forward.
Dr. Suman, should we try again?
So shall we? Yeah. I just
tried logging off and on.
Yeah, I just wanted to, we had a question from Professor Sudhin about the DSMB interim analysis. You've actually already answered it, and there are a host of other questions waiting for you in the question and answer session. So if you don't mind, we'll skip this. We will try another time with Professor Sita. Over to you, Professor Sita.
Unmute, please now. Unmute, yeah. You're still muted. Please unmute yourself. I think we're on. Okay. Can you say?
Okay.
Perfect.
Is it working?
Yes.
Very well.
Okay.
Thank you.
Thank you. Thank you. I apologize for, all the audiovisual problems. And I have to say, we've had some very interesting presentations, a lot of very interesting data that's been presented. I will try and answer any questions that you have.
So Professor Sita, our question to you was, you have been working for, almost 2 decades only in this, and you have seen how it has changed practice all over the world. Now, when the results of the HELIX came out, what were your impressions of why it is not working in LMICs?
Well, the first thing was that, the population, there is a difference in the population between the infants enrolled in HELIX and the infants in the high-income countries, mainly looking at the infants in helix, really had a very early onset of seizures. So that is different from the infants that we have seen in the NICHD trials. That was one thing. The other thing was, in our very first trial, as was pointed out by Sudhin, we realized only when the trial was over that we had elevated temperature in the control group. So you have to remember, this is 1998, to 2003. So we didn't realize, because actually, if you look at a normal newborn nursery, nobody really monitors temperature so closely on infants. And we realized only after the trial was over that the infants in the control group had elevated temperatures. So, and we've published on that, and we have another paper coming out now on blanket temperatures among these infants. So having elevated temperature in the control group, in the cool cap trial and the NICHD trial is different from the helix trial, where it was very carefully controlled in the control group. And I will say in the current NICHD trials, we are doing a trial now on preterm infants. We do control the temperature in the control group. And as was pointed out in the adult and pediatric trials, the large ones that have just been published, temperature control in the control group is a big focus. So that was another difference between the helix trial and the prior trials. One question that I had among the data that's been presented, and it's a lot of data, it's hard to assimilate everything, is the patient selection. So you have to see that both in the helix trial followed the NICHD criteria for patient selection. So the infants had to be severely acidotic or need resuscitation at birth. They had to have moderate or severe encephalopathy by certified examiners, within 6 hours of age. So, and all other causes of encephalopathy were excluded. So that was also another, major thing with helix that I think strengthened the helix trial.
Thank you, madam. You have highlighted that probably the patient population was different. There was higher hypothermia in the NICHD, which may have shown a larger difference between the cool group and the non-cool group. And also that patient selection was very similar to the NICHD trial. And therefore, maybe it's the population which is different, which could have affected the impact. So we move forward. Thank you very much for your words. And then let me share screen again. So we now move to Professor Vishnu Bhatt. Sir, you have done almost, I think, 6 trials, randomized controlled trials. And I remember when we read your first randomized controlled trial, and then subsequently many more came out. Why is Professor Vishnu Bhatt still continuing with randomized controlled trials and not, using it as a standard of therapy? So what took you so many trials to decide, yes, fine, now it should be the standard of care in JIPMA?
Yeah, it's a good question. I wanted to convince myself and others that it is really working. What happened was, the results were so excellent or extraordinary. Sometimes when anything has gone wrong, why we could get such good results? Although I was seeing most of the babies myself, but we wanted to 100% sure about what we are talking about. So we looked at the oxidative stress, we looked at the DNA damage, various aspects, whether cooling has any benefit or not. Otherwise, it may be by chance, as Steve or other people are telling, the brain is already damaged or the problem is there. That way of thinking, whether cooling is effective or it is by chance it is getting. So you looked at the oxidative stress, there is significant fall with the cooling. We looked at the DNA damage. The DNA damage halted when we continued cooling. So there was definitely better outcome. And all over the country, we would have conducted more than 50 workshops, training hundreds of pediatricians. And all of them are, many of them are doing cooling. And many of them come to our center. They were working for 10 to 15 days to learn the technique, and then they go back and do cooling. So till people are convinced, I wanted to show what I was talking about. Is it by chance or is it really that? So like our Sudhin also looked at the changes in the DNA. So these are the changes occurring because of stress. It is not because they are already damaged inside the uterus. It may be inside the uterus when there is an obstructed labor, when there is a cord around the neck, some problem intrauterine, it can happen. Otherwise, it definitely it is not completely genetic. There will be genetic difference between white, black, east, west, all those things. But I think that is negligible. Therapeutic hypothermia is 100% effective. Definitely, it is if anybody comes says it should not be done, we are doing harm to the infants. That is what my thinking. But always you can question.
Thank you, sir. Thank you. And we are very, very grateful that you have actually brought out such large data on a randomized control trial on this, because many of us, I know, have jumped onto the bandwagon 1 decade earlier and started cooling without data from India. So your data has really a lot of precious value for all of us. And you wanted to be, I think, doubly or triply sure before you used it as standard of therapy. But we also need to remember that you have cooled inborn babies, whereas Helix was, the large chunk was outborn babies. And that is where probably the difference could be. And we may have to really focus on what we have to do for outborn. So now let's move forward on the panel. So we have controversy. We have one large trial, very well conducted trial, which shows that it is not beneficial. Let's remember the primary outcome did not show a difference between the two groups. That is, survival free of disability at 18 months was similar in the Helix trial between the two groups. Mortality was higher. But on the other hand, we have considerable number of data from premier institutes, well-conducted trial, which have shown that it is beneficial. So now what is the way forward? And we have to give our listeners some sort of consensus statement. And with that, I come back to Professor Sita. The big burden of asphyxia is in the low and middle income countries. So now what is the next step for them? I mean, we can't sit and say cooling is not effective. What can we do? So should we still think of having more studies? What is the way forward in Southeast Asian and Sub-Saharan Africa? The other question is, when we show this data, and you also show data of Professor Sudhin showed that from low socioeconomic status, it might be not really, helpful. So is sort of Helix widening the quality and equity chasm, which is already there in low and middle income countries? Over to you, Professor Sita.
I think one thing has to be understood, and that is the Helix trial is the only trial that was powered to look at death or disability. The only trial conducted in the LMICs that was powered to evaluate death or disabilities. So that is an extremely important finding from individuals who do clinical trials. And I have a lot of experience with clinical trials. So you always power your trial based on your primary outcome, not on secondary outcomes. So the results of the trial did show that when you have targeted normothermia versus targeted hypothermia, there was no benefit of targeted hypothermia in reducing death or disability. So that's something very important that one should keep in mind. The trial, as was pointed out, was evaluated by a totally independent data safety monitoring committee that was unaware as to what the two groups were. The data they saw was group X versus group Y. And so they saw the data during each of the interim analyses. And they had the responsibility to monitor the trial and also to decide when to stop for either benefit or for adverse events. And that was their responsibility. And that's what they evaluated. So I think we need to put that in perspective, really, because I do want to emphasize Helix is the only large trial conducted in the low and middle income countries with a primary outcome, with a population that is generalizable, because it included, as you pointed out, both inborn babies and outborn babies. And it included the spectrum of institutions that could take care of these infants. Now, coming to, what is our way forward? As was pointed out by many of the speakers, trying to improve prenatal care and improve the obstetric approach, I think, is extremely important. Maternal disease, that is extremely important. And I think we will learn a lot from the PREVENT study that is ongoing, that is looking at neonatal encephalopathy and what can be done to prevent that. The other thing that I think we all should know is to monitor any infant who's born with a low APGAR score or with birth acidosis carefully for, for elevated temperatures, to monitor them carefully. And I think the big question is, can we use can we use pharmacological therapies for these infants in LMIC? I think we need to wait for the results of the HEAL trial that will come out, which is erythropoietin, and also to wait for the results of the trial that is being conducted in the LMICs with erythropoietin. So it's going to be a combined approach. It's going to be, looking at obstetric care, looking at neonatal care. Mention was made about maternal transport. I think that's a very important factor, transporting high-risk mothers to perinatal centers, as has been mentioned, continuing the good care that's being given in the inborn centers by all the presenters. And then, then let's see, is there something else that we can use that has been studied in a large scale setting that might help. So it might be the erythropoietin or darbepoietin, might be magnesium sulfate. I think we have to wait on that.
Yeah, thank you, Professor Sita. You have highlighted two major aspects, and we know from the newborn survival series that focusing for care at birth and on the mother probably has the highest evidence. And also you talked about newer pharmacological therapy that we need to wait for. But you also, we also noticed that you did not talk about looking at cooling again in these settings at all. So that's another point that we noted, but we'll move forward now. Thank you, ma'am. Thank you very much. And this is a question I would like to ask Professor Sudhin. Now, you have led this large trial in Helix. Now, would this results of this change your practice in the UK? For example, when a baby comes in with seizures at, say, 2 hours or so, or a baby comes in who is from the Southeast Asian origin and has signs of like seizures or maybe hypothermia on admission, are you going to decide that you will not cool these babies based on Helix? Over to you, Professor Sudhin.
Yeah, that's a very interesting question, Suman. I think, in Helix trial, we did not recruit babies from the UK. So the recruitment was only from India, Sri Lanka and Bangladesh. So it's difficult to extrapolate, but you make a very important point, and so did Professor Vishnu Bhatt. What do we do with these babies who have seizures occurring within a couple of hours of birth? We don't see that often in the UK, but there are some, and I suspect in those cases, cooling is not going to work. And that's where we are. So at the moment, we are trying a couple of drug therapies. We initially tried Xenon, we didn't work. Now we are trying erythropoietin and avipoietin. We'll see how. But this is what happens when to these babies who are fitting within a couple of hours. And I'm quite interested to know from Professor Vishnu, but because in your studies, especially in the Ghana paper and Tanlingam, they almost 80% had seizures within randomization. So how did you find these babies? Did you think cooling was still effective? Because in the UK we don't find that, and all the data from high countries it shows if babies fit that early, injuries are occurring earlier, and your window for cooling is closed. So cooling doesn't work. So what is, I want like to know Professor Vishnu Bhatt's view on that when you had such a high incidence of early onset seizures in your population.
You mean to say early convulsions or convulsion during cooling?
No, early convulsions at the time of randomization. So the Ghana paper and Thani Gallasam, both of them, 81 and 83% had seizures at the time of randomization. So was cooling still effective on this baby?
They did not have convulsion at that moment. They had convulsion during the cooling. See, there are two different.
In the paper, it says at randomization, those infants had seizures.
Yeah, they did have convulsions, but not at the beginning. In the process, they did have convulsions, many of them. So you are telling.
So a randomization was done within 6 hours. When did you randomize them?
Look at the convulsion for randomization. Some might have had, but definitely not as much as you found. You found almost 80% having convulsions. So this shows already severe brain damages occurred before you started cooling. So these babies, what I'm trying to say is that they were not resuscitated properly because we don't have data. They don't have an ABG. They don't know how they were transferred. So what I'm trying to say is that these babies which you have cooled, most of them are already damaged. So the 70%.
You're absolutely right. Absolutely right.
Yeah. So that's the problem. It is not a genetic. It is the care which is given.
Yeah.
Which has to improve. Which Madam Sita Sankaran was telling. The care has to improve. Antenatal care has to improve. Proper delivery should be done. Proper transport should be done. Because temperature before cooling is also important. Their hypothermia, both will cause damage. Since ours are all inborn babies, they were controlled temperature transfer. We did not find any hypo or hypothermia as such because the temperature was controlled right from the birth.
Yeah, I'm referring to the papers by Ghane and Tanlingam.
I think maybe we can move on because discussing individual papers now may not be in the interest of time. We agree. I think I don't think there's anyone who will disagree when we say quality of care at birth, during transport, all has to be improved. If you want better outcomes with or without cooling, I think that is beyond any discussion. And I hope that your PREVENT study will also show us how this can be done and we can scale it up very rapidly. But I guess that, when something is standard practice in the UK, you may not be able to make any changes based on other studies in LMICs. We understand that. But when I actually first read about the helix, what came to my mind was the ACT and action controversy with people who are familiar with, because I have been closely associated with the action trial. We know that the ACT trial, which showed in a cluster randomized control trial, antenatal corticosteroids, when it was scaled up, and where the entry into the enrollment was not very rigid, it actually showed harm. And then it took WHO to bring about criteria for antenatal corticosteroids and say you have to be in imminent labor, you have to have the quality of care. And the action trial, which came out last year in NEJM, has shown very clearly that it works. So my question was to Dr. Ismat Jahan was, like Bangladesh is in a state where you're not considering cooling at all. But if you were going to do another trial on therapeutic hypothermia, would you choose your patient population differently? Over to you, Dr. Ismat.
Thank you. So my big answer will be yes. First, I look into the population characteristics and all the pathophysiologic and other factors that might relate it to pathophysiology of hypoxic ischemic encephalopathy. Then I'll think about intervention, whether it works or not.
Yeah. Thank you, Dr. Ismat. And I think now we have some sort of way forward, which Dr. Kiran More will discuss. And this is the NNF position statement on therapeutic hypothermia in India. Over to you, Dr. Kiran.
Thank you, Dr. Suman. I know we are running behind the time, so I will not take a lot of time, but basically the whole purpose of this webinar was to come up with some consensus and way forward. Already, I think we heard and from Professor Sita and everyone else, what needs to be done. But can we just do everything based on one single trial? And the questions which were going on in the neonatologists or the academicians in India, they were like, whether we need to relook at the data, whether we need to pull this data again. And a great effort was put by the NNF working group, led by Siddharth Ramji, Deepak Chawla, Praveen Kumar sir, and our Dr. Suman also was part of this group. And they did a quite extensive and good work to pull off the data in a very short period of time and looked at all the trials again and individually looked at the data, particularly raising the questions again about the the mortality and the neurodevelopmental outcome. And there were about so you can see there are about 24 RCTs were found, and there were 7 in the high income countries and 17 in the LMICs. And I'll just quickly go through some of the slides to show the full data of all these trials through the Forest Blast, and then we'll come up with some consensus on it. So as you can see in the high income countries, the pool analysis still show that there is a reduction in the death before discharge. This is what we are trying to look at, death before discharge. The heterogeneity was low, and the pooled outcome was 0.77, so reduction in the death. Similarly, if you look at the LMIC, there are a number of trials which looked at it, and even if we added Helix trial from the data from the Helix trial, the results are showing there is a reduction in the mortality, and you can see the heterogeneity is low in this. So overall mortality reduction is 0.76 with a good confidence interval. Looking at the death before discharge studies now, where the pH has been reported. Now it's very important, again, the issue has been highlighted. What was the condition at birth determines the outcome. So we need to know about the pH status at birth and also the temperatures at admission. So if you look at those babies who are very sick with pH less than 7, in those also, if you look at HIC, there's a reduction in the mortality, and even if you look at the pool data at the LMIC, there is overall reduction in the mortality. Now, if you look at the pH more than 7, so these are the babies which are born in a better state, the benefits are in fact better. There is a significant reduction in the mortality. Again, the heterogeneity is low here. So again, babies born in good conditions do well. Now, if you mixed all these babies and if there is no clear-cut information about their condition at birth, and if you pull all these data together, looking at all the trial, including the Helix trial, then the benefit is not much. So you can see this crossing it's only 0.96 and it's crossing the midline. So there is no benefits has been reported. Now, other important thing is about the outborn and inborn. Again, this is a very important issue has been highlighted. So if you look at the death before discharge and where there are no outborn neonates, so all are inborns. If you look at the LMIC, the outcomes are quite favorable. It's 0.6. So there is a reduction in the mortality. But if you add outborn newborns into it, the reduction, there is not much difference. And you can see it's crossing the midline. So again, it is a very big confounder for cooling babies who are outborn, so especially when you don't know which condition they were born in and how they were transported. Now, again, another important factor, what is the outcome of death if the admission temperature is less than 36? If they're not normothermic at admission, then you can see then there is no difference in the death mortality before discharge in this baby. But if the admission temperature is normal, then you can see there is a reduction in the mortality. Again, highlighting very important about the care of the babies. Now, this is another scatter plot and linear regression line between the proportion of neonates who had severe HIE and those who died before the discharge. So blue is the intervention arm. So you can see the blue are the babies who are in the intervention arm and black were in the control arm. I mean, just to summarize this, basically more severe, the severity of the HIE, more the chances of the baby will be dying before discharge. And again, as we all see this, the mortality is higher in the severe babies. So again, it depends on what kind of a population of babies you're including in the trial will influence your outcomes. Now, looking at the death or severe disability at 18 to 24 months, if you pull high-income countries, again, it has been shown, obviously, there's a reduction there's improvement in the, there's improvement in the disability outcomes. But yeah, if you pull up all the data now, recent data, including the Helix trial, there is still improvement in disability, a long-term disability at 18 to 24 months of age. Again, the heterogeneity is not too high in these studies. Now, looking at the cerebral palsy at 18 to 24 months, again, HIC high-income countries, it is 0.73 and it is 0.69, including the data from the Helix trial. So there is improvement in the cerebral palsy. So it was concluded that this is from the NNF paper, that their conclusions were that therapeutic hypothermia does reduce death and severability, disability and cerebral palsy at 18 to 24 months, even in LMIC compared to high-income countries. Mortality before discharge for moderate to severe HI for the babies with cord pH less than 7, there was a significant in both the groups. And so again, it's favorable. But hypothermia at admission and unclear evidence of severe intrapartum asphyxia, that's a group where there's uncertain benefit from therapeutic hypothermia and it may cause more harm. And the risk of death was increases in the presence of severe encephalopathy. And that's why, again, it highlights the need of invasive ventilation, inotropic support. And that again highlights the issue that optimum NICU facilities are needed if you want to cool this baby. And the question still remains about the ethnicity, biological factor, genetic variation, difference in the intrauterine exposures. I think these all still need further studies, whether we can conclude and say with the affirmation that this does make a difference. So their recommendation from the practice is what actually we have already been discussing, and this is the NNF statement for the practicing neonatologists in India. So the first question is, where should the therapeutic hypothermia be offered? So yes, no doubt that it should be a high quality neonatal care, level 3, level 4, especially the nursing ratio. If you try to care for this baby, try to have a 1:1 or 1:2 nursing, and you should have all the routine facilities for monitoring. And Professor Vishnu highlighted that very much. And which neonate should be offered? Again, yes, these criteria are pretty standard. More than 36 weeks. Again, some centers try to do even more than 35, but this is what they proposed. And important is to start within 6 hours, and the admission temperature should be in the normal range. And the criteria followed are again pretty much same criteria which followed worldwide. And which neonate should not receive therapeutic hypothermia? That's where the important question lies. So babies who are again very sick, presenting and with congenital or genetic abnormality, severe growth restriction, severe coagulopathy, if there is a head trauma, intracranial hemorrhage, and then presenting beyond 6 hours of age, these are the baby we should probably not cool. And what future from here is, I think we still need individual patient data meta-analysis for all the trials from LMIC to address some specific issue. And there is a high urgent need of a national registry of all the neonates, because there are so many centers in India. We're cooling the data, but I think it's high time to pull this data and come up with some more concrete conclusion. Thank you.
Yeah, thank you. Thank you, Dr. Kiran, for summarizing it so clearly and in such short time. I know we are running late. I'll just straight away ask Dr. Sridhar, what are your thoughts on this NNF statement?
Thank you, Dr. Suman, and thank you, Kiran, for summarizing it so nicely. Obviously, the focus here should be on the points that we have learned from the Helix study as well, that outbound babies are not a homogeneous group. And before I address the point on the statement, I would like Sudhin to consider the question of, there was a study published by Vanya Olivera on the pilot project for the Helix trial. And even there, it was clear that 70% of the babies were outbound, and you had a clear differentiation in the outcome between outbound and inbound. So could we not have gone back and changed it? And the other point is awareness of what exactly happens in the Indian scene. When we talk of a center like Institute of Child Health in Chennai, for example, everyone works hard, no doubt about it, every decade. But there are so many constraints. And when we talk of outbound babies, coming to a center like Institute of Child Health is mostly hospitals who have burned their hands and they want to push away a dying baby. So essentially, we are talking of a situation where we are having a very sick baby who has not received the optimal care, and that optimal care is going to damage the brain even more. The absence of a good Apgar score, the absence of documentation of the Apgar score, I mean, the absence of the COT pH and the early seizures, the subacute changes on the brain MRI, it doesn't mean there is suboptimal antenatal care alone. It may also mean the postnatal care has been suboptimal. We all know that cooling is going to prevent further brain damage from the secondary brain injury. It's not going to reverse the brain injury that has happened. And we are talking of a situation where the brain injury is poor in this case, mainly because outbound babies are a totally different category. So it's not to criticize the study. You have done a great job. It's obviously a very difficult position to organize, as Dr. Sita said, the biggest number of babies who may have the power. But did we choose the right babies? Professor Bhatt and Dinesh also asked the same point. I mean, did we choose the right patient load to come to a conclusion which we aim to extrapolate to an entire population in all the low and middle income countries? My point is it's not. You have not chosen the right population. So we should go back to the drawing board and think about why we didn't change based on the pilot project. You have spent a lot of money, the funding is there, the training has been there, the data collection has been meticulous, I accept everything, but if your soil is not the right one, are we going to get the right results? And we cannot compare a baby who is outborn, who has received very poor care, to a baby who is inborn, who is going to get the optimum care from the beginning. We may show genetic differences, but it's not going to be easily understood by many of the people. And what is clear is that they are cooling babies, they are seeing a benefit. And so unless we have comparable populations, we cannot. And the NNF statement, my main comment is going to be what Kiran said in the end. The registry is going to be critical. People should really have a clear documentation of what kind of babies. I mean, it was very interesting when Dr. Dinesh presented his data that close to 60% are still outborn. And so if you say don't cool outborn babies, it's not going to be the answer, because outborn babies also do not need to be discriminated. But we should be very careful in, especially the referring center should be very careful in documenting from the start, trying their best to optimize the care, documenting from the start what exactly is being done, be very transparent. I know it's a very litigious subject. It's a high risk of medical legal problems. So people may hide information. They may try to push the baby away. That happens in any setup, but in India, it happens even more. They just want to wash their hands of the patient. Please go to the next center. It's their headache after that. But we should come to an open system where we address the problem. We give them the clear information, try to optimize the care and documentation, and the registry is going to be critical. So I was thinking of saying the outborn babies should not be cooled, but if you don't have enough information on the outborn babies, do not cool them. Or if you don't know or you don't trust the center where the baby is coming from, it's safer not to cool. So you may damage such babies in cooling. So my comment is to be, the NNF has to take the lead along with IAP in creating a registry with utmost urgency. Having the statement is important, but more important is to monitor what happens subsequent to that. After the ACT study, the WHO came out with very clear criteria, and it's very nice to know Dr. Suman was part of the team. So such criteria have to be applied, I mean, by our bodies first and maybe the WHO later, partly because this will protect our team medico-legally. Most of the questions on the chat about the medico-legal implications, I don't think people would be blamed for not cooling in the Indian scene now. And at the same time, you won't be blamed just on the basis of the Helix study for cooling a baby as well. That is not enough evidence, especially when the scientific community sees that the patient chosen for the study is not appropriate. So both sides won't work. You don't need to be worried if you don't have the facilities to cool or transfer, and you won't be blamed for cooling after the Helix study as well. So this is my humble viewpoint, that the registry should be applied immediately, and there is a huge responsibility on the referring team in entering the appropriate data. So the referred team, the team to whom the baby is referred to, can make the appropriate decision. Thank you.
Thank you, Dr. Sridhar, for saying it so very clearly that now it's a total no blame game in India. You can cool, you will not get blamed. You don't cool, it's still not a standard of therapy. But totally take your point that we need a registry. And that's what we had actually started when we started doing with the Mira Cradle. All of us who were using the Mira Cradle maintained a registry and came out as a paper also after that in the initial time. And then I think we all got sort of, oh, cooling is, we are fine with it, we are comfortable. And what Helix has sort of done to all of us who believe in cooling is shaken us up a little bit, made us run back to our data and look at it. And here I give an example of why I think outborn babies have a problem. And this is our inborn baby. This baby did not cry at birth, was floppy, required ventilation. And my resident was all set to cool. And when he called me up, he said, Madam, everything fits into the cooling criteria. Then what's the problem? The problem is your cord ABG. The cord ABG did not satisfy the cooling criteria. And obviously the decision was not to cool. And then when we looked at it, what my resident did not pick up was the cryptorchidism, was the high arched palate, was the lesser coils in the umbilical cord, which were all there. And this was actually a case of a neuromuscular disorder. And that's where I think, especially in South India, with 1/3 of the population in consanguineous marriages, I wouldn't be surprised that many of the babies who were cool may have come into this. And therefore, I do believe that a cord ABG is a must. We somehow need to have it. And we saw that in the NNF statement. And at least in my unit following Helix, we are very, very careful about our outborn babies. We have told our residents, if you're going to cool an outborn, you better call us up and let's take a decision together to decide whether this baby should be cooled. So my question to you, Dr. Dinesh, is how will the NNF position statement affect cooling in the private sector? You all will be definitely so concerned about the medico-legal aspects, and then most of your babies may be outborn. I know you have a good retrieval system, but how does it affect you all?
No, I think, thanks, Suman. See, I think what the NNF statement is saying is, one thing it is very clearly highlighted is which type of unit should be cooling. So, I think it has never contested that cooling is harmful. It said cooling is a therapy which can be given. But the unit should have 1, 2, 3, 4 facilities is one thing. So I think that is one part which should be there. I think which is very important, I think, that as you said, and I say that Helix trial has just alerted everyone that you just can't just cool and keep quiet, that you need to have 1, 2, 3, 4. The second thing which has come up is to identify which type of patient should be there. So question of, okay, this child is not right, you just pack them up and send to some other hospital so they can be cooled is not what we should be doing. But if you want to do any good to the child, to organize a good transport service for this child is something which got highlighted. And which is what I would say is need to strengthen the emergency transport services both in the public and private sector, which is what I highlighted about. Even in our case, they were 50%, close to 50% were transported by us, and other have come in. We do not know how many could not reach. Maybe the sicker one could not reach. So there could be some bias in that. I agree with that, I take that criticism also. So I think the statement, what it says is, yes, identify the type of patient, identify the type of unit, stress the importance of having cord ABG, which is what we have to work with our obstetricians, have some more perinatal meetings to ensure that most of the unit which are taking care of this type of patient should have cord ABG as a routine care, so that we identify these patients, and you, as you presented the previous case, that you differentiate between asphyxia for a child who had a neuromuscular diseases. And finally, I think it's very important that who should not be cooled also has been identified. So identifying the population who is not going to benefit, it has been cautioned, and now see some of are very clear cut, they were not going to benefit a big bleed or someone who's come with coagulopathy, another thing, which is what the statement has been given by the NNF. So I think from private sector, I think cooling is going to continue. I don't think we would have anything to say that we cannot do cooling in LMIC. The only thing, identify the patients, don't take them, less than 6 hours is the time, though there have been studies that, can we cool after 6 hours and all the things on. You have to, the time frame when you start cooling is also very important. Transferring them, and not during transfer, it is not just only the temperature. Did you maintain their oxygenation well? Have you prevented any hypoxia post set of resuscitation? Because secondary injury can happen post resuscitation also. Have you maintained the blood pressure normally during this phase. All these things are also going to be very important during. So I think the importance of transport has also been stressed. And I think there will be a lot of debate upon what type of cooling machines to be used, servo-controlled cooling versus phase-changing material. But one thing is very sure is that you should start cooling ASAP in less than 6 hours and maintain the temperature and prevent hypothermia is something. So I think as far as consenting is concerned, I think it is, since it is a standard practice in Western country with the definitive evidence, I think you take consent for blood transfusion, you take consent for invasive procedures. Whether we should introduce that, something is, we might review that. But one thing is definitely, I think we should probably all of the centers, and I think as an NNF, we have level 3 case which are sort of accredited by NNF. We can develop an NNF registry and say whoever is cooling should be reporting that. And then we can look at and review the data in years down the line to see what is happening for all the centers which are cooling. And that way we can come up with some robust data.
Yeah, thank you, Dr. Dinesh. I think we all should work towards creating this registry, which will have large number of babies. I think I have only one more question because I know the audience are waiting patiently. And maybe we already heard a lot on it. So Professor Vishnu, but maybe if we can have a very short answer on the 1, 2, 3, 4 prerequisites that a center should have before they start cooling.
Yeah, so I put up one slide also on that.
Yes.
So one thing is the manpower. I think Dr. Dinesh has given most of the required details. You should have enough nursing and monitoring facilities. There should be continuous monitoring all these infants, both his rectal and body temperature has to be monitored, and any complication they should be taken care. So you should have ventilator facility, you should have ABG machine, you should have neuroimaging facilities, and you should have good care. That is very, very important. That's why level 3 care, probably NNF is also stressing. So unless you have sufficient care, because during cooling complication can develop, then you will be held responsible for cooling without having facilities. So it is not like giving paracetamol to a fever patient. We should be very, very careful, I think. And any procedure, the parents have to be informed, whether you give blood, whether you put an IV line, whether you do cooling, they have to be told the pros and cons, and they have to be taken into confidence.
Yeah, thank you, sir. Quality of care is so important to every outcome that we look at. We have more questions, but I think we need to go to the audience. And I hand over to Dr. Aravanan to take on, and you have a difficult job of going through so many questions and filtering out a few to manage in this time. Over to you.
Yeah, absolutely. Thank you, ma'am. May I know how much time do we have
15
before
minutes
I start?
I think only 15 minutes we'll have to wrap up because I think
because I have a lot of questions. Maybe I will direct to each one of you. I selected a couple of questions, and a lot of people writing in chat box as well. Thank you everyone for their excellent contribution. I will start with the first question for the recent speaker, which is Kiran Moore. One of the delegate was asking why the NNS position statement did not grade the evidence. Unlike other position statement, what was the quality and certainty of the evidence from NNS position statement? To you, Kiran, a very short answer.
So as I said, it was a statement. It was not a CPG or a guideline. There's a need for making a proper clinical practice guideline, and grading and evidence and everything takes time. So I think this will happen probably in the near time. But I think the idea was to quickly look at the data and publish data, and they came up with the consensus. But yes, there needs to be a full thorough process needs to undergo for grading and evidence and everything, which is I think will be coming soon. And maybe Dr. Suman can answer.
Yeah, I can answer that very well. See, we had this thing of coming out with a statement at super speed because people were concerned about getting sued for malpractice if they cooled. And therefore, we needed to look at literature and CPG guidelines, take time. The next set of CPG guidelines has taken more than a year for us to bring it out. And because of this need to bring it out, it was a quick review of whatever published data was there. And we did not look at, the quality of it, whatever was in the public domain. If it was randomized control trial, That is what was considered. We had Dr. Ranjan Pejawar in a group telling us, when is it coming out? When is it coming out every week? And that was exactly why it came out in super speed, and it did not go through the rigor of grading or risk of bias assessment. That hopefully should come out in the near future.
Thank you, ma'am. And I think the next question to Professor Sudhin. And how many centers who were part of ELIX trial stopped cooling after the results? Professor Sudhin?
Well, in Helix trial, none of them are cooling. But I just, the pilot study we did in ICH, that was on outborn babies. It was a non-randomized trial, and it showed 50% reduction in mortality with cooling. So this is why non-randomized trials will show a selection bias and will show benefit. And like Sita said, the only evidence we have on cooling from LMICs is from the Helix trial. So that is definitely, scientifically, there is no basis for continuing cooling in LMICs, especially in private settings. That cannot be justified. So none of the Helix trial sites are cooling.
So as of now, all 7 centers are not cooling for therapeutic hypothermia.
Yeah. Even the centers who were cooling previously, like Hubli, they all stopped. I mean, they are, there have been a lot of, MD thesis, this kind of studies going on with cooling, but many of them are kind of stopping. Yeah.
Thank you, Professor Sudhin. Which brings another question. Dr. Ismat Jahan mentioned about they started cooling with the ELIX trial only. They don't have any prior experience. Compared to other 6 centers, this center is totally different, which one of the delegate asked the question about the internal validity. How do you address that? I think the question is about this center is starting cooling with ELIX only, but other 6 centers might be doing cooling for a long time. And I think the question is the question of internal validity. I didn't understand completely, but that was the.
I can take that, Arvind, because all the sites we did extensive training. I think between Sita and I, we got reasonable experience of cooling therapy. So we went out to all the sites. So we are literally hand-holding with each of those babies. And Ismet sites in Dhaka, that's one of the top premier universities. It's like the aims of India. They have one-to-one care. And Ismet is absolutely brilliant neonatologist there. And there's a full-fledged team. And they were one of our best group in the Helix trial.
Okay, fine. Thank you, Professor Sudhin. I think that.
Arvind, you're muted accidentally.
Sorry. Yes. So I'll go with my next question, which actually to Bud sir. Whether DNA study was done in severe hypoxia or moderate hypoxia babies. If it is done severe hypoxia, it cannot be extrapolated into mild moderate hypoxia. And can there be an observed bias?
The DNA damage, what we have looked into is the mean difference of the damaged DNA between the cooled and uncooled group. So it includes both moderate and severe asphyxia. It is not the individual one. I showed you some pictures where normal cell, when you do electrophoresis, how do they look like? When mild hypoxia, what happens? Moderate, severe. So as the severity increases, oxidative stress goes up, DNA damage also increases. So similar thing what Dr. Sudhin was showing on the DNA will happen, because whatever stress is severe, it will cause DNA damage. It will reflect on the DNA, and definitely it will be seen. We have done some studies with sepsis, not with asphyxia. The sepsis babies who are having poor outcome are different in the sense their methylation, everything is different. Their sequencing of genes have been done. They are different in the sense it is not the baby itself. There will be some difference between the babies because the parents are different. Their DNA markers are different. So individually there will be variation. But it does not mean if baby with sepsis comes, you don't give antibiotics. Any sensible person will not tell. Suppose if a baby comes with sepsis, will you give antibiotics or not? Or because your DNA is different, you don't give antibiotics. That is the point I am trying to tell. If you do ventilation for all hypoxiated babies, your mortality will be 80-90%. But if you put a ventilator more than 95%, almost 100%, they survive. So it depends upon the selection of cases. If you do a best cardiac surgeon, does cardiac surgery, when the patient has gone to cardiac failure and has become very sick, operate, he will die. So that is the thing. See, here basic problem is the case selection. That is the main issue with the helix trial, which I am trying to tell. Whether Sudhir likes it or not, he is my good friend also. So I have to tell what I feel. I have told him all this, but
sorry, yeah, of course, yeah, we'll be always good friends. I need to go in 2 minutes. Is there anything more for me? I don't know.
Sorry. Yes.
Is there any questions
there
for
is
me?
one question. I think you can answer, or Professor Sita can answer. I think they did mention about the TOBI trial and NICHD trial that hypothermia in the control group was high, which caused a deleterious effect in the control group. And so are we thinking that the beneficial effect of cooling is kind of masked on those trials? Would you like to kind of redo the trial in this high income countries to prove the cooling benefits?
I think Sita can take that. I'll make a move then. Thank you so much.
Sure.
Thank you, Professor Sudhin. Thank you for joining.
Bye-bye.
Thank you very much.
I don't think it is. I don't think there's going to be any trial that is going to look at, elevated temperature that is controlled versus hypothermia, because you have to realize the fact that there was elevated temperature in the control group was something that was actually discovered during the trial. So it really brought up the fact that that if you were to evaluate temperature among HIE infants, that many of them have elevated temperature. That was brought out at that time. So subsequently, after the first 3 major trials, 4, including ICE, after the first 4 major trials were published, then everyone really is being very careful about temperature management. So there really is not going to be any study that will be done, because the data is very convincing. We showed that the risk of death or disability goes up with every 1 degree Celsius increase in temperature. There have been non-invasive studies that have evaluated brain temperature that have demonstrated that elevated brain temperature is associated with with death or disability. So it's very unlikely that there's ever going to be a trial looking at that. But it's pointed out the fact that we need to look at temperature management. If you look at the adult trials for cardiac arrest and the pediatric out-of-hospital cardiac arrest and in-hospital cardiac arrest studies, the reason that they really are cooling is because they have noted in their populations that there was elevated temperature among brain injured adults and pediatric patients. So I think it's quite a well-known, well-established fact now.
Thank you, ma'am. I think one more question to you. I think it's specifically about that if provided that NICHD is funding another trial in low-income countries, and you are kind of have a choice to select centers, which is kind of different than the 7 centers, would you kind of run the trial with the large, like adequate power and everything? Would you think that the outcome would be different?
No, I don't think I said NICHD is going to fund.
No, I think it's a question about that. Is there another trial coming in? So do you think that is going to change the outcome if the selection of centers is different? I think that's what
Well, I mean, any the studies that are done are really based on the amount of funding to do the studies. And so, whether you look at the TOBI trial or the ICE trial or the NICHD trial, it's the funding agency that decides how much they're going to spend and then invites centers to participate. The NICHD trial, the first trial we did was about $1.4 million, which many would consider expensive, but it really costs money to train all the centers, make sure everybody is very well trained to select the infants, and then to do the study conduct. So doing randomized controlled trials are very expensive. A major part of the expense is follow-up. And for a hypothermia or any neuroprotective intervention, your outcome really should be follow-up, not just death in the NICU or death at discharge, but it should be follow-up. And the earliest follow-up where we can actually confidently diagnose cognitive and motor problems is 18 months of age. So I would encourage the NNF to also include that any infant who is cooled should be followed to 18 months of age.
Thank you, ma'am.
Just one more question to Sita ma'am, we can answer because I can ask because Sudhin has left. This is comment from Dr. Shilpa Kalane. In Helix trial, the sentinel acute perinatal events were less than 30%. Upcast scores were less than or equal to 5 to 10 minutes. Less than 50% of the Helix patients were inborn, and less than 50% were assisted ventilation. And cord gases were available only in 10% of the Helix patients. So this suggests that more than 50% of the Helix patient would have probably not have been eligible with Sita Shankaran's 2005 study. So
no, that is incorrect. The enrollment criteria were exactly the same as the NICHD trial. The conduct of the trial was the same, and the follow-up was also the same, except that we used Bailey 3 rather than the Bailey 2, because by that time, the Bailey 3 was published. So the inclusion criteria were infants who were equal to or greater than 36 weeks gestation and who had pH less than 7 at birth or within 1 hour of age. And if the pH was not available, they had to have a history of a perinatal sentinel event and need for resuscitation that was continued for a minimum of 10 minutes. So the criteria were very, very strict. And the criteria were checked on every infant at the time of enrollment.
Sure. Thank you, ma'am. Over to Ervan.
I think many of the questions were already answered by the panelists and the speakers, so I don't want to repeat all the questions unless one of the panelists wants to ask any questions. Otherwise, I will hand it over to Dr. Suman, ma'am. Thank you.
Okay, so I don't do any of the panelists want to respond to anything else in the chat or the Q&A?
Can I make a point about the question that Kiran raised?
Yeah, please, Dr. Sridhar.
I think the Helix trial centers have a moral obligation not to cool because they're part of a study and they have to stand their ground. But for the other centers, I don't think that holds. So their position would not be a medical legal position. And again, one study funded and it's a high quality study in terms of numbers. The patient choice, there are so many articles which have criticized that study in both IJP and Lancet. So I don't think any court will hold you wrong for cooling just on the basis because the cooling is said as in a negative tone by the study. So that is my view. I would like to hear what the other panelists think. Professor Bhatt and Dinesh have already made their points. And I don't know if Professor Sita has any comments on the medico-legal position based on this. What does she think?
No, not really. I'm not familiar with the medical legal climate since I've actually, been in the United States for the last 45, 46 years. So I'm not aware of that.
Can I add one point?
One way to look at it is maybe how the US courts would react if a study like this comes, where you have a significant finding. I think the one very important finding from the Helix trial that I see is that the cheap equipment that was designed does cool well. So if at all the centers decide to cool, they can. I don't know if they are released to market it now, or what will be the impact? Will they be stopping? Because Sudhin mentioned in the beginning that they will only produce commercially after the study results. But now, because your study doesn't recommend it, would they still be released to produce that equipment? Because you showed that it works well. It's cost effective, it works well. I know it doesn't have the servo control, but still for the purpose of keeping it in that temperature range, it works well. So it's probably better than the phase change materials, as Sudhin pointed out. So this could be a positive we take from the Helix study. But I'm not sure about the legal impact of that on the company as well.
I think.
Oh, we can't hear you, ma'am.
You please unmute, ma'am, again. You're muted. Please unmute again. We can't hear, Sel.
Something.
I think because the computer has given up, I think. So
actually, what I'm trying to say is that if a baby is eligible to cooling and you have facility, if you do not cool, I think you will be medical legally sued for not cooling. If you have facility and if the baby fulfills the criteria, if you do not cool, the other way around. Now, prevent study, heal study, so many studies want. They may want babies who are not cooled, but I think it will be unethical not to cool the babies if you have facilities. Tomorrow you will be sued, definitely. See the prevent study, heal study, if you see, they want infants who are not cooled, in the sense they want to see whether that is effective or not. But it is ethically wrong. You should not hold cooling if the infant requires cooling and if you have facilities. That is my impression.
I agree with Dr. Vishnu, but I think, see, when there is a proven therapy and we're saying that you should not use it just based on one study, probably you're more liable medico-legally. And by not cooling specifically, the child fits into the criteria, comes to your hospital in these things, and then you say, no, based on the Helix trial, I'm not going to cool. I think you're going to be a lot more in problem. That's my personal view.
See, those who are in the foreign countries, they are safe. But those who are in India will face the problem.
So my suggestion had been, and I think we're closing down, my statement would be, and of course, prevention is best. Try to sort of be in close and try to encourage cord ABG by having more perinatal meetings. Second is, look at for those babies who qualify for cooling based on those who require resuscitation, based on the cord ABG or based on UpGuards. If you decide to cool, ensure that your unit has the facility, infrastructure, monitoring, and medical expertise and nursing expertise wise to do that. If not, transfer them appropriately to a center which can do that, is what I would say at this stage. Now, for those who still sort of believe or do not, I think someone has raised that in the chat box. Let's maintain the registry of what is happening at this stage. And this, ethically, I still strongly believe that we probably are not right to do a RCT based on this. This is my strong opinion. As a country, we probably cannot subject our babies to a randomized control trial, because I've seen many babies who had, I didn't get chance, who had pH of 6.7, 6.8, bad asphyxia, who have done wonderfully well on follow-up. We'll share our follow-up data very shortly, but yes, and it has been well proven that it does help, it is protective. I think it is a type of injury which is there. Yes, If it's a chronic hypoxia, it doesn't help. Just because chronic hypoxia doesn't mean acute hypoxia doesn't happen in our country. So choose your patients well and cool. That's my message for today. Thank you.
Thank you, Dr. Dinesh, for your message. I think we can go to the final messages from all panelists. If Dr. Kiran, would that be fine?
Yeah, of course.
Yeah, so I think Dr. Dinesh has given his message beautifully. Professor Vishnu Bhatt, what message would you like to give?
No, that's what I said. You should cool. First of all, you should have enough facility. Secondly, the infant should fulfill the cooling criteria, what is laid down. If they are fulfilled, then definitely you should cooling. And cooling should not be done in places where there is no facilities and you cannot monitor the patient. Obviously, you should not do. And I think regionalization of cooling facility and proper delivery, proper resuscitation, appropriate transfer to these centers and cooling will be the best. But of course, we have a long way to go because finance may be one of the major issues. I would have been very happy if HELIX study, some fund would have been spent on improving the infrastructure, which would have helped many people.
So thank you, sir, for again emphasizing about quality of care. Now I request Dr. Isma Jahan for your message. If it's a one-liner, it was even more better.
Yes. Thank you. So to sum up, intervention efficacies, trial finding, results will talk in its own way. So trial findings itself, publications itself, systematic review in course of time. So we just need to wait and see, and we will understand and we will take decision what we need to do for our babies. Thanks.
Thank you, Dr. Ismat. Dr. Sridhar?
I would like to congratulate all of you. So excellently organized, and I'm sure it's a very useful session for everyone. My point is that I think I agree with Dr. Dinesh, but we should wait for the registry data for 5 years or so, establish the registry on a war footing, make sure it's collected stringently, review the data before we design another study, because we don't want to burn your hands with repeating a study like this. There is a lot of effort into all these studies, so we should get the right information. So compare the outbound, inbound, compare the private hospitals, government hospitals, and make a clear decision on the patient choice when it comes to designing the next study. And hopefully that may be the first long-term, multicentric study in this format from India. Thank you.
Thank you, Dr. Sridhar. Professor Sita, I don't know whether Madam we can hear her, but I would just like to, Madam has typed out here. Very interesting discussions based on HELIX. I would not encourage cooling until there is, then I can't see what else. Maybe more data or a registry. Okay, so
she's answered one more comment previously, I think.
Yeah, and Madam has cautioned, Professor Sita Shankaran has strongly cautioned us on the therapeutic creep, and make sure that you're not cooling the mild encephalopathies. And there's no efficacy data or safety data on these babies. So thank you, Professor Sita Shankaran, for giving us your 3 hours for this panel discussion. We thoroughly enjoyed having you here. I would like to make one comment, which we keep hearing here. Quality of care, I think that is the most important aspect that we need to strengthen. Yes, if you think, like, for example, if your NMR in your unit is low, I think cooling probably makes a difference, definitely for your inborn babies. And if you're doing it well, maybe you could continue. And registry is something that we need to do on a war footing, but we need to be cautious on our outborn babies. We need to find a solution. Maybe we need to go and retrieve them, transport them, take care of them, have a liaison with the centers which are sending us these babies, but we need to be cautious for our outborns. And I hand over to Dr. Kiran More and Dr. Aravanan for their final comments. Thank you.
Arun, you go first.
Thank you, Kiran. Thank you, Dr. Suman ma'am. Thank you, Professor Sita and other panelists. It was an excellent session. I think I don't think I had an academic feast in last 2 years because of the COVID. This is an interesting session. Learned so much from all the senior people, and I too agree with all the panelists' comment. And thank you, ma'am. And we do be very cautious with not to cool mild HIE and preemie babies until we have more efficacy and safety data. I think that's a kind of take-home message for myself, and I'll hand it over to Kiran. Thank you.
Perfect. Thank you, Arman. Thank you. I mean, I will not repeat anything. I think everything has been said repeated times. I hope the messages are clear now. And this was the whole idea of having this session. I would just like to thank everyone, all the faculty.